your life.
So good evening, everybody, and welcome to the second edition of Personalized Medicine Applying Research. We've already done one chapter before, and we discussed, other, dimensions of applying this research to personalized medicine and personalized care for our patients. So today we'll be looking at three different other new categories. It is molecular biomarkers, retinoblastoma, and ocular immunology, and COVID, which is like the big thing. And we also have a keynote by Dr. Barun Kumar Nayak, where he'll be talking about personalized ophthalmology and if that's even a possibility. I think that's going to be a very, very interesting talk, and we look forward to that. Before we go into the talks and the keynotes, let me first introduce our panelist and my co-moderator, Dr. Arko Subra Ghosh. Gives me great pleasure to introduce him. He has obtained his PhD from the University of Missouri, Columbia, and he's done work on molecular medicine, gene therapy, and also did his fellowship from the Institute of Molecular and Cell Biology, Singapore. He set up the GROW Research Lab in May 2013 with the goal of performing patient-directed discovery research for application in future diagnostics, drug repurposing, and novel therapies. A database of mutations in genes associated with genetic disease within the Indian population is also being established for future recombinant vector-based gene therapy and cell replacement modalities under his leadership. A clinical vector production platform is also being developed, and various functional genetic studies are being done with the aim of performing clinical gene therapy trials. Arko has several patents, awards, publications, and chapters to his credit, and I could go on and on. So great to have you as a co-moderator, Arko. I'm sure you'll be able to steer this, meeting and discussion in just the right direction. And going on to our panelists, really proud to have very, very eminent researchers, clinicians, translational scientists amongst us. First and foremost, we have Dr. Tara Prasad Das, fondly known as TPD amongst us, our circle. Welcome, sir. He's currently the Vice Chairman of the LV Prasad Eye Institute. He's a Professor of Ophthalmology at the Sun Yat-sen University in Guangzhou, China. He's the Adjunct Professor of the Ophthalmology at University of Rochester Medical School, Rochester, and the Fellow of the National Academy of Medical Sciences, India. He's also the Regional Chair for the International Agency for the Prevention of Blindness, that is IAPB, President of the APVRS, member of the Research Committee of APAO, or Associate Editor of the APJO, and many, many more. He's the former President of the AIOS and the VRSI, and the Chairman Program Committee of RO USA. The IJO celebrated the Golden Jubilee when he was the Editor-in-Chief of the journal. Dr. Das has received several awards from state, national, and international societies, and he was conferred the Doctorate of Science by the Rayshaw University in 2011, and the highest civilian award, the Padma Shri, in 2013. Welcome, sir. I'm sure you'll add to the deliberation of our meeting today. Next, we have Dr. Vishali. She's a professor, an accomplished vitreoretinal and uvea expert of international repute. She works at the PGI Chandigarh, and she has a keen interest in inflammation and infections of the eye, and there's a lot of original work on intraocular tuberculosis, fungal infections, and diabetic retinopathy. She's a sought-after speaker and has delivered more than 870 invited lectures and conducted several instruction courses at various international and national meetings. She has more than 190 publications in peer-reviewed journals and has edited 4 books and contributed to 62 book chapters. She's a member of the International Uveitis Study Group, American Academy, the Club Junes Conan, and the Macular Society. She's currently the Vice President of the USI, the Chair Scientific Committee of VRSI. I think these are some of the older posts that she's held. And she's received various awards and holds a US patent for multiplex PCR. Welcome, ma'am. Pleasure to have you amongst us. Next, we have Dr. Kasturi, very dear friend. She's the Director, Clinics and Academics of Sri Shankar Deva Nethralaya in Guwahati. She heads the Department of Orbit, Ophthalmic Plastics and Reconstructive Surgery, Oculofacial Aesthetics, and the Department of Cataract and Refractive Surgery at Sri Shankar Deva. She's a recipient of more than 38 national and international awards, and Dr. Bhattacharjee has been a global FRCS examiner for the past 15 years and is the review of many national and international journals, having over 65 publications and peer-reviewed journals. She's the first ophthalmologist in India to start navigation-guided transorbital optic canal decompression surgery, for which she has received the best paper at APAO. Welcome, ma'am. We then have Gopal. I hope he's joined us. I can't see him, but I will nonetheless introduce him. He will be joining us soon. Gopal is a professor and head of the Department of Ophthalmology and the chief of VR services at Amrita at Kochi. He's an eminent VR surgeon in South India. He has pioneered 25-gauge sutureless retinal surgery in India. He completed his graduation from Thrissur and has postgraduated from RP Center in Delhi. He also has completed his DNB and FICO fellowship at McMaster University, Hamilton. And he has an academy certificate course on AMD. He's a member of the National Diabetic Macular Edema Task Force, several publications to his credit, and several presentations across different fora. Then we have Dr. Namrata Sharma, needs no introduction. She is the Honorary General Secretary of AIOS, and she's also professor at RP Center. Her clinical work includes PACO, foldable IOLs, refractive procedures such as LASIK, PRK, and SMILE. A keen interest in corneal transplantation, DALC, DSEC, DMEC, we all know about it. She has over 450 publications, and an honor to have you amongst us, ma'am. Welcome.
Thank you,
And we also have Rajesh Sinha with us. He's the Honorary Treasurer of AIOS, and he's working as a professor of ophthalmology in the Cornea, Cataract, and Refractive Surgery Services at RP Center. He has done his specialty training from RPC itself, and also completed several other degrees, FICO, FRCS. He's also done a fellowship at the University of Washington and has over 300 publications to his credit. Welcome, Dr. Rajesh.
Thanks.
And we will go over to the sessions now. Pleasure to introduce Dr. Barun Naik. He's the president of AIOS currently, and I have worked with him personally for several years when he was the editor of IGO, so known him closely, and I really appreciate his dedication to the work that he does. He also shoulders the responsibility as head of the Department of Ophthalmology at PD Hinduja Hospital at Mumbai. He works with a belief of practicing ophthalmology ethically in the best interest of the patients, and he provides ophthalmic care to the highest standards in all fields of ophthalmology. He practices general ophthalmology, phaco, lasers, retina, vitreous, everything. He has a special interest, of course, in glaucoma, as we all know. He's the second vice president of MOS and has been the past editor of IGO. He's also associate various ophthalmology associations, several talks, workshops. He promotes education in the field of ophthalmology, several books and several papers presented today. Over to you, sir, to deliver the keynote address today. He'll be talking to us on is personalized ophthalmology a possibility?
Chaitra, can I just say a few
words? Yes, ma'am, please. And yes, before
I just want to thank you, and I want to congratulate all of you for this excellent topic. I think the topic is really good, and what began as personalized medicine single webinar is now going to be in 3 chapters, because we have so much of material on that, which is the way to go, because it is not about treating patients in general, but it is about targeted therapy for targeted patients, given the fact that everybody responds differently, the genome is different, and so that is why things have to be done differently now. So I'm sure it is going to be a great webinar yet again, and we have another one after this, which is chapter 3, which would be coming very soon. Thank you.
Thank you, ma'am, for the opportunity from AIOS. And madam had spoken about this personalized medicine, reality, the last chapter, and that was very popular. So now we're going a step forward, and we'll be talking about personalized ophthalmology itself. Over to you, sir.
Thank you, Dr. Chaitra, for the lovely introduction. It's really means I always get embarrassed if someone introduces me. So I just wanted a short introduction, but I don't know from where did you pick it up. And the The second thing, I also share the same view as Namrata just now, what she said, that these kind of webinars really, as I said earlier, also attracts me more because this is something which is going to be useful for majority and which is required rather than just repetition of the similar topics. Okay, so straight away going to the topic which is given to me to answer, is personalized ophthalmology a possibility? Now, this question I am answering, I will be answering, or I am in this group as not as any researcher for the translational research, but as a comprehensive ophthalmologist who is going to be, why it's not showing, why it's not moving.
So you can use the arrows on the slide, sir, left bottom corner.
Which one? Sorry, just a minute.
Just move your cursor to the, they will be on your slide.
The cursor on the bottom left.
Yes, yeah. Now it's okay. So as a comprehensive ophthalmologist who will be basically taking the benefit if this sees the light of the day in future. I must admit I have no financial disclosure to make, and also I have been asked to answer that question, but I must say that neither I am an astrologer nor a professor. So I cannot do prophecy, but definitely I have a wish list that this should come through. And but for the listener to judge whether it will be a reality, possibility or not, I'll put forward some facts which they can judge for themselves. Now, this personalized medicine, precision medicine, individualized medicine, everything, all are the same terminology, same word, and meaning same thing, which last time very nicely elucidated in the first part of your program by Dr. Namrata Sharma. Now, in the current philosophy, because this was the editorial, I picked up from about 15 years back, I had read, so I remembered that. It was because it appealed me that time also, and it also, I also had similar feeling that some glaucoma patients will never deteriorate whatever little you do, while some will continue to deteriorate whatever maximum you do. So it means there are many things which are unknown. There are many factors which are unknown. And why it is so? Because right now the traditional medicine which is on the theory of one size fits all, means one diagnosis, same treatment. So there is no difference. But this personalized medicine is primarily to segregate it further so that you can have a better diagnostic value, prognostic value, and treatment modality. So in this, what is done, I will not go in detail. Namrata explained last time very nicely that any diagnosis or disease, it can be further stratified, or those factors going to the genetic or the molecular level, so phenotypic and genetic characteristic. And based on that stratification, you can individualize the treatment, which will affect the counseling, also the targeted conventional therapies, personalized therapies, and also helps in screening and prevention. Now, it has unlimited potential. There is no doubt about it. Right now, some research is definitely going on inherited eye diseases, retinal conditions, glaucoma, corneal disease, retinoblastoma. Some of them you heard last time, and some of them you will be listening more today in detail. Now, there are many challenges which we have to see. One is educating and updating clinicians, which is a big challenge because right now the current teaching modality or the teaching pattern is entirely different. So it has to change completely. So especially those who have already passed out, they have to be again educated, and regularly they have to keep updating because the science is developing so rapidly. The gene mutation identification, of course, it's a lot of progress is being made, but a lot more requires to be done. And there are so many things which are still not very clear, that there are some variability of inheritance, the incomplete penetrance, variable expressivity. So those things, of course, as we move forward, it will be made very clear. I mean, it will be definitely more clear. Now, also, it needs a definitive proof that genotypic specific therapies are really beneficial. Now, right now, all those things, it looks, sounds, must be sounding for the majority a foreign language and nothing understandable. But For personalized medicine, these things everyone has to understand, and there will be many more. It is right now just I have put up over here, but there will be many more which will be coming in future as the progress will take place. For this, the testing also is a challenge, because it will be deterrent for a patient to undergo testing unless some intervention is possible. And once it is diagnosed, then they should also know, suppose gene therapy, something abnormal is detected, then it has to be corrected or it has to be altered or whatever way. So that also needs a rapid progress. The diagnostic technology need to be easily available. Right now, it is available only at select few very advanced centers. So that has to, because if it has to be popular, it has to be in common practice, then that need to be expanded. The last time I heard about electrophysiological investigations, and I'm sure everyone just simply knows what are the tests. Probably they are just limited to that and some waves, A wave, B wave, something like that, but nothing beyond that. But it needs better understanding, which I understood last time. So that again, because that was just part of it. The testing guidelines have to be created for all tests. The consent and ethics, because the consent is also necessary. The ethical issues also will come, because suppose some genetic deviation is noted and it has some implication, then whether it is to be disclosed to the patient itself, because if it will be that you are predisposed to certain things because of this detection, then that person will be psychologically upset, whether right now it is not affected, but in future. So that is again a big issue. Then even this also is reality, especially in India, is not so much, but in US, that the insurance companies, if something abnormal detected, it has to be disclosed at the time of insurance, taking insurance, and they may put a loading factor or a loading amount for the premium, or sometimes they can even refuse doing covering the medical coverage. Because why I am aware of this, because in one of the research, one person contacted me that this is the consent form, informed consent, which was sent to them. There were so many things which was written that if there is some complication develops, then you will be, then we will be doing it, we will be treating it, but we will be billing it to your insurance company. If they don't pay, you have to bear the cost. Similarly, any test also, similar thing. If the insurance company doesn't cover right now, it will not cover majority, then you have to cover the cost. And but when this was pointed out to the researcher, they said, no, but these things will not happen. We are just mentioning it. So it means they are safeguarding their interest. But the patient interest, if something happens, then they will say, this is the thing that you have signed. So these things need to be considered. Support from that, therefore, support from patients also required. And certain orphan diseases, because if we come to know some orphan diseases, which the incidence is very, very low, there is a limit of certain per country. So if that, because the company also will not come forward for developing orphan drug market, because there is hardly any orphan drug market. So these things need to be considered. Then artificial intelligence, lot of role of machine learning and artificial intelligence will be there. So it needs use data analysis, need for better infrastructure for data, idea to algorithm, it has to be developed. Then robust clinical validation of those algorithms, safe implementation and widespread use, adaptation by stakeholders based on demonstrable value of AI system to their patient. And so patient's involvement is also equally important. And finally, so that if these steps are fulfilled, then finally AI system can move to frontline clinical practice. And for me, for anything, any new treatment or for any new modality, means I basically look at from 3 points. That if it satisfies those 3 points, probably it's going to be a great success. What are those? That it has to be a proven benefit, definitely superior over whatever the current practices are. The second is ease of treatment, the learning curve. It cannot be very steep. The ease of treatment, institutional treatment should be simple and easy. And finally, this definitely the cost cannot be ignored. If it comes at a very high price, then India, it cannot be a success or it cannot be a popular thing. So it needs collaborative efforts of academic institutions, patients and clinical network, regulatory authorities. And now, at least I'll just put up one point here. At least now some of the governments have recognized that this personalized medicine is important, and because it can be just confirmed by this fact that in 2016, President Barack Obama allotted $215 million for development of personalized medicine. So it means that the government also have thought of it. So then probably there is some hope. The commercial companies also have to come forward, and pharmaceutical industries also should come forward, and it has to be, with no uncertain term, it has to be cost effective. So finally, I am sure whatever point I have put forward, anyone can judge for themselves what is the future. So I wish that it definitely has a potential for development, but challenges are many. But I am sure in future, maybe next generation, this will become a norm, and this teaching will be normal, and this is what it will be practiced. And whatever currently we are doing may be just referred as history, just like we always talk about cataract surgery. Whenever we talk about couching by Sushruta. Thank you very much for your patient listening.
Thank you, Dr. Nayak. You have summed it up perfectly. So, I mean, taking a cue from what Dr. Sharma also spoke about in the last meeting, you have said it right. The key challenges that particularly face us as scientists, as well as for the clinician scientists, is to make the bridges so that the discoveries from the lab can actually cross over and become tools in the hands of clinicians. So one question that I would like to ask you, just to follow up on what you just said, is for any new technology, there is a certain amount of learning curve. You mentioned that the learning curve needs to be smaller, shorter, because of the dynamics of the clinical practice in India. So do you think part of this learning curve can be shortened if more newer techniques and newer knowledge is imparted at the medical college or at the training level? And what can be done about that?
Oh, you are right that means this awareness has to be created, and all those things. But then I think the burden is more on people like you, who are the researchers for the translational medicine, because you have to come out with something which is easy to adopt, not something which is very, very difficult and it's a brain teaser. If something like that, then again means that's probably it will not be a success, because you see majority, I mean to say that 95% people, means those treating physicians or surgeons or whosoever it is, they are lazy people, because they simply want that someone should give me ready-made and just like this fast food, and I should simply deliver it and consume it. That's all.
Right. So
that the more responsibility on is on people like you, and I'm really thankful and to this Narayan Netralaya for taking this initiative for some time now.
Thank you so much, sir. Chaitra?
Thank you, sir. Really nice and very concise, without going, too many elaborations on each one of the possibilities. I think you've summed it all very well. Dr. TPD, would you like to add a little bit on what Dr. Nayak said? Probably post your segment point of view if there's anything specific. So please
unmute myself. No, Varun did a great job, and seeing there are further talks on poster segment, particularly diabetes. I think we will confine to that and not right now comment anything, except that Varun did a real good job. Wonderful job.
Thank you, sir.
Thank you, sir. Thank you, sir. So we'll go over to the next talk. Rajiv, over to you as you share your slides. Quick introduction. Rajiv is a good friend. A lot of work happening. I think 3 core fields that he works in is ophthalmology, screening, and imaging, all about diabetic retinopathy itself. Several publications, several grants, several talks, chapters to his credit. As we all know, he works at SN, and he's actively involved in a lot of population-based studies as well. So he's going to be talking to us on a very interesting topic. Over to you, Rajiv.
Thanks, Dr. Chaitra. Thanks for giving me this opportunity to talk or share some work on gut microbiome and diabetic retinopathy, which we have been doing at Shankanetralaya. Next couple of minutes, I'll be sharing this work. And let's first understand what is microbiome. So all the microbes, probably trillions of them, which we share our body with, are microbiomes. Majority of them being bacteria, though there are fungi or viruses also, which become a part of microbiome. And if you look at the number, we are talking of at least all the cells of the human body, at least that many number of bacteria also reside in us. So we are at least as much bacteria as we are humans. Some basic facts regarding microbiome. Each of us differ in microbiota. Even in the same individual in different parts of the body, there are different microbiomes. And these microbiomes, they help to create an ecosystem which is integral to health, such as digestion, immunity, both adaptive immunity and innate immunity. And what I'll be mainly talking about is the gut, which has more than 1,000 species of microbiomes which are there. And people have tried correlating the gut dysbiosis, where this balance of microbiome gets affected, and diseases. And it's not new. Even in 1930s, there was a work where people created some germ-free mouse, and they added microbiome, and they found that there was a rapid weight gain. And they attributed that probably obesity can be a microbiota-induced trait. So people have correlated this from a long time, and of late, majority of including hypothyroid or cardiac illnesses, even CNS abnormalities like Parkinson's or Alzheimer's, obesity, type 2 diabetes, definitely there, inflammatory bowel disease. People have correlated all these diseases with gut dysbiosis, where the balance of the microbiome gets altered. And of late, many of the ocular diseases, including AMD, uveitis, diabetic retinopathy, dry eye syndrome, people are trying correlating the altered gut microbiome with these ocular conditions. And before I tell about what we did, there is a different language for microbiome whenever we talk about microbiome studies. The bacteria are not identified by the classical staining, but by the 16S ribosomal RNA sequence that is used for classification of bacteria. And there is a term called as OTU, that is operational taxonomic unit. The bacteria which are grouped by DNA sequence similarity, they form one OTU. And there is a term called as relative abundance, that is how common or rare a OTU is relative to other OTUs in the same community. And there is a term which is very commonly used in gut microbiome studies called as diversity. It is the degree or the amount of variation of the microbial community structure within a sample, which is called as a alpha diversity, and between the sample is called as a beta diversity. And how you measure these alpha diversity is by 2 parameters called as richness and evenness. Richness is the count of number of different species which are present in a sample. And evenness is the measure of relative abundance of different species that make up a richness. And there are many indices with combination of these 2, richness and evenness. These are indices which represent the alpha diversity. And how we analyze these gut microbiomes? By a next generation sequencing, where massively parallel sequencing of genetic material is done in a short period of time in comparison to what was traditionally done with single DNA thing, the Sanger sequencing technology. And as I had mentioned earlier, the sequence microbes are based on genetic code rather than the morphology and staining. So this was one of our work which recently got published in IOVS, where we tried associating the gut microbiome abundance with sight-threatening diabetic retinopathy. So we had essentially two groups, a group with no diabetic retinopathy with more than 10 years of diabetes, controls, and we had cases which had both, which were sight-threatening diabetic retinopathy, proliferative retinopathy, and diabetic macular edema. This is the overall microbial abundance, and what we are looking, this is the kingdom which we look into, the life kingdom, the animal kingdom. These are the phyla. So these are the various distribution of phyla of all the microbes which were present in our population, both cases and controls. And if you try to differentiate between cases and controls, we did find that there were higher Bacteroides species in cases, and there was higher Firmicutes in controls. And if we look at ratio, Bacteroides to Firmicutes ratio, this ratio was altered, and that was significantly higher in sight-threatening diabetic retinopathy cases as compared to the controls. That is the BF ratio. And if we look at what contributed to this increase, so if we divide this sight-threatening retinopathy to macular edema and PDR, so it is the macular edema which contributes to the increase in the BF ratio, not the PDR. So probably BF ratio, or this Bacteroides to Firmicutes ratio, can be a potential marker. So we tried looking at, can we find a cutoff to differentiate between a sight-threatening diabetic retinopathy versus control, and this was using some of the statistical tools, and this cutoff was 1.05, though not a very great sensitivity and specificity, because you see in the middle area, there are a couple of them which are not falling in the two zones. What can be the possible mechanism? So whenever there is a gut dysbiosis, these Bacteroides, they release these endotoxins and lipopolysaccharides, which trigger an innate or a natural immunity. There are pro-inflammatory markers which get increased, leading to macular edema. We also did a secondary analysis trying to find out correlation of alpha diversity, as I had mentioned before, the richness and evenness with sight-threatening diabetic retinopathy. And these are the 4 indices which I had mentioned before. So there was no difference between cases and controls if we just look into these 4 indices. However, if we again look into what we found in our first analysis, the BF ratio, and if we see BF ratio, definitely a couple of if the people who had BF ratio more than 1, these indices were lower. That means lower diversity was there. And again, if we try to correlate in which group this belonged, so it was surprisingly not macular edema, but proliferative retinopathy, meaning that there's the degree of variation of a microbial community structure within the sample is less in proliferative diabetic retinopathy with a higher BF ratio, meaning that if BF ratio is high, in PDR, the diversity between the microbial communities is less as compared to those where BF ratio is normal. So there is something which is happening in PDR. We know there is ischemia there. What happens to ischemia in other organs? So the similar findings of a change in alpha diversity was also noted in people who had cerebral infarct. That means probably these changes in alpha diversity does reflect some changes because of ischemia. And what can be again the mechanism possible? Again, increased Bacteroides, reduced diversity. And there's a good work done by Dr. Maria Grant, who has tried looking at possible mechanisms, and she has told it's increase in arachidonic acid metabolites and leukotrienes, again increasing. This is the one which causes the proliferative diabetic retinopathy. So what our study at Shankanetralaya, we found that in DME, there is alteration in relative abundance, there is increased BF ratio, and in proliferative diabetic retinopathy, there is a reduced alpha diversity in presence of an increased BF ratio. So what possible implication these studies have? Probably we can identify people at risk of having sight-threatening retinopathy by doing a stool test. Again, very early at this stage, but definitely a lot of work has been happening in this field. And can we identify people who have more risk of sight-threatening retinopathy? There is good work done by Dr. Maria Grant on blood-based biomarkers, metabolites which are mediating these gut microbiome-induced changes. These are basically secondary bile acids like TUDCA or the TLR reporter strains. These blood levels, again, probably reflecting the changes which are happening in the gut. And like what has been happening in many of autoimmune diseases, therapeutic interventions. There are a lot of animal studies on intermittent fasting, dietary interventions or probiotics or fecal implants, which have been used in treatment of many autoimmune diseases. Probably in diabetic retinopathy in future, we may see these modalities as some of the treatment. I'd like to thank my gut microbiome team, Abhishek, Avni, Rehana, Ramya, Ronnie, and Rahul for helping me doing this study. Thank you very much. Any questions? I'll be happy to take.
Wonderful. Brilliant talk, Dr. Raman. So this is really opening up the application side of things now. So microbiome analysis, folks have been doing for a long time, I think. So how do you think because for some of these broad phyla that we look at, they do change across many different diseases. So how do we apply these if they are, I mean, the same kind of change is applicable across many diseases? This is a problem that we face as well when we talk about biomarkers. So
yes, I agree. That's the reason if you look at the sensitivity specificities were pretty low. It was not that great. We tried looking, initially the moment we found this cutoff, we thought that, wow, something good. The problem of all these biomarkers are the same, that it's very difficult. It may not be a biomarker for disease, but it does show that it does play a role in the pathogenesis of diabetic retinopathy as such, sight-threatening retinopathy, macular edema, and PDR. And I think Dr. Das will add, he has done some very beautiful animal studies, recently got published. I didn't include it because I saw Sir's name and I thought Sir will definitely highlight that, because that's a work next level after doing these studies, doing animal study to really see whether any one of these, because intermittent fasting, there is a lot of work that, but again in rats, it reverses retinopathy, but whether really in humans that has been happening is something we need to see. Yeah.
In fact, there was a recent, post on one of the groups that said that they have seen worsening of diabetic retinopathy in people who are doing keto and doing IF.
That's because of a rapid control of diabetes. So we know that whenever you suddenly reduce have a very tight glycemic control, there are changes or retinopathy level increases, macular edema increases. So probably that may be the reason that sudden control or sudden glycemic control may cause it.
So you want to add something, TPD sir?
Two phyla Raji mentioned called Firmicutes and Bacteroidetes. In addition to that, two other phyla who are also predominant dysbiosis in people with DM and or DR are Proteobacteria and Echinobacteria, which is published in +1. And these four, Firmicutes, Bacteroides, Probacteria, and Echinobacteria, combinedly, they are the major phyla in a person with either human control or diabetic or non-diabetic, and they are 98% to 91, 92 to 98%. What you also found that in addition to Bacteroides, which Rajiv talked about, that Actinobacteria also less abundant in people with a DR compared to people without diabetes or diabetic retinopathy. So all these bugs are actually pro-inflammatory. In fact, all the research indicates that inflammation plays a major role in diabetes and diabetic retinopathy particularly. Now, we are also not surprised that because we all know on our sample also do a microbiome, not microbiome, identify the fungi. We find that several fungi are also involved in as a pro-inflammatory, anti-inflammatory in gut microbiosis, and particularly Candida. Pathogenic Candida normally is a commensal. A pathogenic Candida is involved in people with a DM and DR, and that is very significant. We also identify, Rajiv has done, people with a PDR and non-PDR. We also identified people with a newly diagnosed diabetes within less than a month, and the people who are older diabetes find a significant difference both in alpha and beta.
Could I ask?
Please,
Yes,
please.
ma'am. Arka and Rajiv, amazing talk. Now, my question to you guys is the microbiome is also influenced by your epigenetics and your environment and, so on and so forth. So we have been hearing about microbiome in uveitis for more than a decade. And Rachel Caspi from NEI tried to, selectively give antibiotic and do all that stuff. But my question to you indirect is, would changing the environment and the modifying the external trigger change the microbiome and the disease over a period of time? I'm not talking about this particular patient. I'm talking as a preventive measure in large group of population.
Yes. So as I told you, a couple of these methods of intermittent fasting, fecal transplant, they all change the microbiome. Because these are the ways by which microbiome can be changed. We can change it for good.
But could we just change it by following our Ayurveda?
Maybe that's what, again, these are the things we don't have evidence much. As I told you, the change of microbiome, having change in diabetic retinopathy has been only in experimental animals, Dr. Maria Grant study. So we really don't have a proof that it will work. But yes, these are the methods which can be, and the next step is doing the animal studies and going further for human trials. Yeah.
Vishali, if I can just add to what Dr. Raman said. So essentially the role of these microbes is to provide us with certain metabolites, vitamins, etc. So that is probably the mediator of the signals towards the disease pathology, whether it's inflammation or whether any other tissue damage, wherever is happening in the body. So by corollary, if you are to alter that metabolite or that set of metabolites through dietary or Ayurveda or something like that, you would alter the populations of these microbiota and therefore have the beneficial effect. So that's the logic behind it. So at a population level, yes, it might be.
I'm sorry, my net disliked me. My net disliked me, did not like me. So unlike you all young people. Well, I will conclude very fast that we proved the similar thing almost in a rat study also. So I just heard the last few words of Dr. Ghosh that is very correct, that require a larger population study, and unfortunately cannot be a long longitudinal study to prove that this stuff can decrease or retard diabetes or prevent diabetic retinopathy. So it has to go through the animal work only, that's why. So we showed in our recent IUVS paper, how does it affect the retina. In diabetic, retina actually become thin and then swells up in DR. So we showed that how treating the rat with correct microbiome, fecal capsules actually works. So we have not stopped it and we are continuing. But to say that what is the end of the tunnel, is there a light? No. For next 5 years, 7 years, 10 years, no. But definitely one day that will be a more personalized medicine for chronic diseases like diabetes, which might also improve the health of people with DR or DKD. I stop here.
So just one question to you, sir. Sir, did you look anything about ocular microbiome rather than gut microbiome? Have you done any work in diabetic retinopathy? Not in keratitis or dry eye, but diabetic retinopathy. Do you feel that will have any role?
Too preliminary, we are working on it. I don't have the results yet. But yes, I have thought about that and we are working on it, and maybe 6 months from now, because to get the report from these companies on Illumina are never easy.
Yeah.
Lot of chasing, and you can't, in eye hospital like yours and mine, I'm not talking Nara naturally because they're rich and famous. You can't put your own lab, unfortunately.
Yes.
But both, I just saw Anand and Arka can put their own lab and we can send all the samples to them.
Yes.
So on that note,
come to Rajiv, all of us who are working on this in this area, including Nara Naturalia, should actually collaborate and identify a larger research question and divide into 2-3 smaller segments, so that more people work on the same time, you can achieve faster than otherwise. The good part of microbiome study is that whatever we discovered in India nobody can copy it, because this Indian ethnic food habits will not same as Finland or Alaska, so we are safe. And say that by 2030, we had 130 million diabetic in this country. Then we add up this Nepal, Bangladesh, Myanmar, Sri Lanka, similar food habit, then we have larger populations. Any pharma company, in my belief, should be interested instead of copying somebody else. And nobody can copy you. We cannot copy anybody either here.
And
So think about, yes, Vishali.
When we are doing such a wonderful study like you are suggesting, we should also take into consideration the social status, the the environment and the epigenetic factors, which ultimately we might find are playing a role towards the microbiome.
Absolutely correct, Vishali, because in our paper we always said these patients are from South India, mostly from Telangana, because we excluded people who are non-Telangana, non-Telugu, not food habit, then different vegetarian, non-vegetarian, lot of work required.
A lot of work.
Not easy at all. But then supposing I just suggested that those who are interested or have the capacity and so on to take an early lead, we all join together under whichever umbrella is, then and ask larger question, divide into some smaller segment, then most well we can achieve faster the same thing.
I agree. Very true.
And as you rightly said, sir, industry would be happy to fund that. Industry would be happy.
We have 2 more sessions.
Yeah.
We have 2 more, sections to cover.
Right.
We have not even finished one. I think we can discuss the whole time.
Well,
I'm so sorry.
Let's move on.
I'm muting.
Put a stop. No, and we're also missing Gopal. He's also been doing a lot of work, but he has a personal situation at home, so he wasn't. He just logged in for a bit and he's left. So he has apologized to everybody. And since Sir spoke about lab at NN, so we're going to be presenting a little bit of work done here on the predictive power of biomarkers. And this will be covered by Anand, Swami, Santosh, and Arko. I'm not going to be introducing them. All of you all know them very well. So over to you, Anand, to start off.
Thank you, Chaitra, Arko, and Namrata ma'am and EIOS for this opportunity. So Swami and I are going to, in the next 10-12 minutes, go over how we've been using in our lab biomarkers and a little beyond to predict ROP. So retinopathy of prematurity, first of all, why do we need prediction? Because there are plenty of babies, more than 35 lakh babies born every year. And when you look at the number of examinations that are required, in just Karnataka, we've now crossed about 200,000 imaging sessions and over 3,000 babies screened. Our model is, of course, a telemedicine model where images are taken and uploaded. And since a majority of these babies don't have the disease, a lot of them are going to be called at frequent intervals for follow-up, which they may not require, or at least you should be able to reduce the frequency of their follow-up. So just going back to that number, 3.5 million babies means almost 17 million exams in the country. A lot of these babies, even when we've decentralized the ROP program, it means that they do have to travel from their taluk levels, houses or hospitals to a district level. And this would mean unnecessary travel, which will a logistic issue, a financial issue, and of course, a clinical issue as well. Unfortunately, ROP is multifactorial. We've been trying our best to predict. This was one of our initial attempts where the amount of weight loss that babies had and they regained it, we were able to somewhat correlate which of these babies will eventually end up getting the disease and getting disease that required treatment. But of course, the lure of the non-invasive biomarker was big, and this is work done at our Grow Lab. So we started off, and the tier work in the Grow Lab has been extensively used by Arco's group for anterior segment and cornea. And we began to attempt this a few years ago, where we were taking the tiers and using the same setup that they had to analyze these markers. Now, this was initially a little bit of trial and error. We did not know what would get expressed and how that would correlate clinically. All these abbreviations here are pro-angiogenic factors, they're cytokines, they're chemokines, and they're adhesion molecules. We'll break that up briefly. But what's important in this animation is to show you that at the very first visit of these screening sessions, by taking their tiers and analyzing them, we were somewhat, and then of course serially following them up, we were able to predict which of these babies will eventually get the disease and which of them will get the disease that will require treatment. So to summarize what we've learned from our tier studies, I'll invite my co-speaker, Dr. Swaminathan. Swami, over to you, please.
Thank you, Dr. Anand, and good evening, everyone. So one of the most important lure for molecular markers is to catch it before it manifests. Like, can we find anything which can preempt what is to come? So therefore, we looked at the pro-angiogenic factors, whether these levels get altered even before we can capture it on the imaging system. And what you see here is clearly there is low level of VEGFs were observed in infants with ROP compared to infants without ROP at the first screening visit. What is more important here is the center orange bar. It is those infants who just came to the first screening and they did not have ROP, but later developed ROP, had significantly lower levels of VEGF. And what this means is the mechanism behind is the vaso-obliteration. Immediately after premature birth, it is hypothesized that there is going to be a decrease in VEGF, and we could actually capture that. And in the next slide, what we're going to show is, in addition to VEGF, we wanted to see an additional pro-angiogenic factor. We wanted to see a shadow, not just depend on just one factor. And for everyone's knowledge, angiogenin was the first pro-angiogenic factor which was discovered in 1985, followed 4 years later by VEGF. So we took both of them into consideration. And what you can see is that the angiogenin level was also high in ROP, and a similar pattern. When it came to those babies who are progressing with a progressive form of a disease versus a regressing form of a disease, what you can see here is both VEGF and angiogenin levels were much lower in the first visit in those babies who went on to progress or develop a more severe form of VEGF compared to those who were regressing. But what is most important is to connect the molecular factors to clinical factors. So what we have chosen here is to see its association with birth weight. And among all the various angiogenic factors we measured by multiplex ELISA, what you can see here is angiogenin, which has got a significant negative correlation with birth weight compared to others. And so was the case with gestation age as well. So angiogenin came as one of the lead factors. And how can we use this for clinical decision making in stratifying those babies with and without ROP? And we plan to integrate both angiogenin and the clinical factor, personalize it to every baby. Therefore, we took the angiogenin birth weight or angiogenin gestation age ratio. And what you can see in the ROC curve with a significant amount of sensitivity and specificity, you can actually use this as a predictive model. So at the first time when you come in, you can actually take the tiers and you can measure these and make this particular ratios in front of you. And what happens next is what Dr. Anand is going to tell you, how can we use this clinically. But before that, if anybody is interested in more detail, please do refer to this article, which is available online. And this work was particularly done by our excellent team, Archana Tanuja, Priyanka Chavor, and Anupam Sharma. I need to thank them, including Dr. Shivani. And Dr. Anand, please help us how you are going to take this information to the clinics.
Thank you, Swami. So you've seen now our results. So now how do we take it to the clinics? Well, this is work in progress. Along with all the tier work that we've been doing, we hope to make a point of care kit so that the tiers collected in the rural, in the outreach areas in our program, we are going to be analyzing it there itself. I think Dr. Nayak brought it out very beautifully that unless we make this accessible and affordable, it's not going to work if we have to be relying on the lab all the time. So I think that's as far as the tier biomarkers are concerned. How can we predict ROP using functional markers? This is one of our recent publications in PVST, where we looked at examining contrast using this rather novel method that was not being used before in preterm babies. And we were able to correlate contrast done during the acute ROP screening time with their disease correlation later. So just by lower contrast, we were able to predict what stage and what severity they would have later. And even more interestingly, contrast was correlated with visual acuity measured using the teller acuity and the usual systems months later. So this is something that right at the first and second visit, there may be functional changes going on in the retina which help us predict what's going to happen later. As far as imaging markers are concerned, this is some good work that we've been collaborating with a lot of engineering and associated scientists. We've been able to take images, work on them to get more enhanced features, automated diagnosis of severity like plus disease. But what's really important is using machine learning and deep learning tools to not only detect disease, but detect it early. And this means that even before the disease would go into a stage that requires treatment, the features that we were able to pick up will help us predict that. But again, it makes sense only if we are able to integrate it with our telemedicine program, because as scores of images come out from different centers, it has to go through the AI algorithm and then help us predict which of these babies will need treatment. This is some of the work that has been published. Look at the images below are the automated detection, which is going on directly through machine learning without any expert looking at it. The accuracy is in the early 90s, and of course we can improve, and that's the work in progress. ROP is a disease we can make an impact, certainly because we are treating and screening these babies at a very early age. And when you use the blind person years, more than 700 crores of blind person years or fiscal equivalent of blindness can be prevented in our country alone, just by screening and treating babies in the 10 most populous states that have the ROP problem. And that's the impact, the social impact of making a prediction. On behalf of Swami and the entire KidDrop and the Grow Lab team, thank you very much.
Thank you, Anand. We'll take questions at the end. So we'll move over to Santosh to continue the next presentation. Santosh.
Yeah. Presentation, can you see?
Yeah, Santosh, go ahead.
Yes. Good evening, all. At the outset, I'd like to thank AOS and the Grow Lab team and my management for this opportunity. So I'll be talking a clinical perspective of predictive power of these biomarkers in especially the most common vision-threatening complication, that's the diabetic macular edema. So these are the current biomarkers what we already know and what we do routinely. The imaging biomarkers like OCT, fundus photography, FA, and even the blood test. So here we'll be looking at the soluble factors in the aqueous. So we know these are the pathological mechanisms that can lead to the most sight-threatening complications like a DME, which is basically inflammation-driven, whereas PDR is mostly angiogenesis-driven, which causes neovascularization. So the idea of a predictive biomarker based on aqueous soluble factors is to kind of determine the disease outcome over a period of time, to see the progression of the disease, and even to kind of find a clinical and as well as soluble factor correlation. So why aqueous? Because it has low risk collection as compared to vitreous. It is available across all disease severities. We kind of take the aqueous sample whenever we kind of intervene, especially in cases where the patient undergoes anti-VEGF injections, and even during vitrectomy to have controls. And we know that there is a gradient of soluble factors that can migrate from posterior segment to the anterior segment. So the other factors of non-invasive interest would be tears, which you can really look into. And coming to diabetic retinopathy, it's a well-known fact that it's a multifactorial disease, and it really comprises of the retinal neurovascular unit, which is severely compromised because of chronic low-grade inflammation. It could be because of pro-inflammatory, pro-angiogenic factors. So understanding of these inflammatory factors is really helpful to kind of develop strategies to prevent and treat DR and treatment complications as they come. So these are basically various aqueous soluble factors. There's quite an overlap between pro-angiogenic, anti-angiogenic, pro-inflammatory, and anti-inflammatory factors. There are too many of them, so we'll just try to cover a few of them. So when you come to a real-world scenario, when we look at the macular edema, it's quite a frustrating disease, and there is no clear-cut answer to recurring macular edema or what you call non-responsive macular edema. So what we had done is we had taken a real-world scenario, and at the time of injecting the patient, we had kind of analyzed these factors. And when you look at VEGF to start with, these were high in spongy non-responding edema, depending upon the morphological types of macular edema. Even mixed non-responding also had a high VEGF. And fractal can also, it was almost the same when compared to other forms of macular edema. Now going further, if you look at angiogeny, this was really high in many of the non-responding cases, and especially the adhesion molecules, these were really high in spongy non-responding and even in mixed non-responding edemas. And further analysis also shows that adhesion molecules like ICAM and selectin also were really high in mixed non-responding edema, and IL-8, which is already worked on, which is greatly researched, shows that it was high in mixed recurrent cases of macular edema. So IL-6 is known to induce acute phase reactions and increase vascular permeability, whereas IL-8 is pro-inflammatory and angiogenic cytokine. So we can see these are raised in subretinal detachments when compared to other forms of macular edema. And again, coming to platelet-derived growth factor as well as interferon-induced protein 10, also these are high in SRDs. So moving further, I'll present two case scenarios wherein there was a recurring diabetic macular edema in both eyes. And we happened to kind of upon a pilot study, we have checked these macular edemas, and we have kind of analyzed this aqueous in two different scenarios. This is a 76-year-old gentleman, laser stable DR with CME. So there was an incomplete resolution upon ranibizumab injection. There was a persistent CME. So this is a time wherein we had analyzed this aqueous soluble factors. So if you found that all the levels were raised when compared to the controls, you could see the VEGF and including the addition molecules that were raised. So this was a time after seeing that since there was suboptimal response, we had given a IVTA, which resulted in a complete resolution. But the patient came back 1 year later and with an edema recurrence. This time again, we analyzed this factor. So we could see that this difference was not too much. The VEGF had come down, and even the other factors, especially the addition factors, were more when compared to VEGF and angiogeny. So this was a difference between first and the second visit. So you can see the decrease in VEGF, and whereas there's an increase in addition molecules. So this case shows that the increased cellular addition molecules were there. So, but the VEGF was really low in second visit. So there was no point really giving anti-VEGF. Maybe it would have helped because of its overall anti-inflammatory action also. But IVTA or an Ozurdex dexamethasone implant, which is a pan-steroid, steroid, it's a pan-inflammatory subsiding treatment. So that could really help it. But when we look at targeted therapy in such cases, it could really help, especially if you could address these addition molecules in such cases. Now coming to case 2, it's a case of non-responding DME to start with, poor response with anti-VEGF. We have tried steroids also, but there was a glaucoma response. So, and again, if you look at the factors, all were raised when compared to controls. And but under this glaucoma cover, since the edema was persisting, we had to go with steroids. So this is the second time the VEGF is almost nil, but IL-8 and other factors were still raised when compared to controls. So when we kind of analyze these things over a period of time, the first controls against first visit, second visit, and third visit, we could see a steady decline in all these factors, especially VEGF was absolutely nil after 2 years, whereas these factors were still present. So this is a case of recurring diabetic macular edema, whereas high levels were there at the initial analysis. The diabetic retinopathy was stable to start with, but the targeted therapy in such cases could really help looking at various biomarkers. So this brings me to the conclusion wherein the importance of soluble biomarkers, they vary with time and disease modification. A retrospective analysis, as we have seen in these cases, or even a prospective analysis over a period of time, the loading dose of injections, and when we prospectively analyze these biomarkers, they can help understand the disease progression and outcomes. And these soluble factors, they can definitely be correlated with the clinical profile, like as in we have seen with a spongy edema or a mixed kind of an edema. And this can lead to targeted treatment strategies and translational research. So this is all about aqueous biomarkers, but the future would be a non-invasive method of soluble biomarker strategies wherein we can readily check these biomarkers, maybe with the tears or even aqueous, and then decide on the treatment, whether to give an anti-VEGF or a steroid or when a targeted molecule that can come up later with pharma support. I believe Dr. Arka will be taking this forward with the latest. So
right.
I would like to.
Thank you so much, Santosh.
Thank you.
So very quickly, I will talk about something that Dr. Varun Nayak also mentioned, that we have to put the tools in the hands of the clinicians. So what we've come up with is a means of testing the biomarkers, which can be done in the clinic by anybody, because it's so simple that you don't really have to be an immunologist or a molecular biologist to do it. So these are snapshots of how the tool looks. This is a research tool which has been customized and adapted for use in the clinics. The key feature of this is that it gives you a multiplex readout of a set of biomarkers in about 70 to 90 minutes. So this can be kept in the clinician's office, and it can be run very quickly. And this works not just for tears, it can work for aqueous humor, plasma, vitreous humor, etc. The best part about it is the quick turnaround time. So while the patient is being worked up, you can get these data out. So this is undergoing beta testing now. So these are just some raw results from some of the testing that has been done in the clinic so far. And this is a video of it. So here you will see an example of how it is done for Schirmer strips. So it's a single buffer addition, and this is being done right now by our clinical fellow. So the solution is then just shaken in hand for a couple of minutes and put it in a cartridge, and everything is preloaded. You don't have to add anything. In about 70 minutes, you get a result. So this is bringing the biomarker analysis to the clinic. So hopefully this will not have a long learning curve at all. All right, so with that, I'll stop here. And so this brings us to the end of this first part, where we discussed how we go about selecting the right biomarkers for clinical application, and how you can use it on a case-by-case basis in specific patients, particularly patients in whom the treatment response hasn't been optimal. So, and we also show a tool which shortly, hopefully in a year's time, can be available to be put in a clinic. So with that, Chaitra, do we have some time for questions, or should we move to the next step?
Actually not, because we have 2 more sessions, and I think
yes,
the discussion was pretty good before. itself. I think a lot of inputs have already come, and if we have time, we can have an overall discussion again at the end of if we finish, because we have to wind up by 8:30. But since Rajiv has been doing this, one last comment, since you saw overall work done here, Rajiv, anything you'd like to quickly add before we start off the next session?
No, it's a great work which all of you have been doing there. Only thing, I'm a bit skeptical whether it will translate to the patient care in terms of responder, non-responder. Because as I had probably one of the meetings before also told, it varies a lot. There is regional distribution of these cytokines. If you are taking even in vitreous near the retina versus at the base versus in the mid-vitreous, these cytokines are totally different. Aqueous, it is totally different. And the moment you talk about tears, you had shown the work on dry eye, keratoconus. There are many other things. And the second biggest problem I had even mentioned before was that we don't have normative values. So we really don't know what is normal cytokine level of within the eye. So it has to be something which is how many levels increase it is, like 2 times or 4 times, or like what we did with vitreous was we looked into only those who had at least 10 to 12 fold more increase. Those are the ones which we really found. So here really p-values doesn't matter. The moment you look at all these biomarkers, p-value 0.05 definitely doesn't play a role here. So it is a good tool, and good. The non-invasive tool is excellent one. Congratulations, Dr. Arka, for the great work. But you need to really find the applications. No, that is something
very true. So I completely agree with what you're saying, and that's why we need to
do a lot of clinical studies.
So the normative data point is what is most important. So by the time we are done with our beta testing, we will have 20,000 patients tested. So we will have enough normative data to stratify patients. And you bring about another important point is that if you take something like IL-6 or something which does go up in every disease, how do you utilize it for a particular disease? So that would be by looking at the amplitude. So the amplitude differs between uveitis to diabetic retinopathy to keratoconus or dry eye. So that is something that we need to identify, and that will come from more and more data and more rigor.
I would just share one of the work which we had done here. This is a project of with collaboration with the UK group, Moorfields, and we tried looking at series of biomarkers for diabetic retinopathy, sight-threatening. And one of the markers which really stood apart was cystatin C. And it's not only in Indian cohort, but even in the UK cohort. You'll soon see the publication which is coming up. Really, that is something for proliferative diabetic retinopathy. That is something. So we also looked into many other. Recently, we had a review article which covered that. Cystatin C has been demonstrated for nephropathy, but for retinopathy, it seems to be a very good biomarker.
Wonderful. Congratulations.
Dr. Chaitra, I need to say something to Dr. Rajiv Raman, please.
Okay, that will be the last.
Yes, that's a comment. Yes,
Honavar is going to.
I'm sorry, Dr. Santosh. Sorry about that. So the question about normative data. So if we did breeze through one such hurdle in Dr. Anand's presentation is the importance of using ratios. Arko was mentioning about amplitude. Yes. We can walk away from being obsessing about normative data rather than looking at ratios of key critical factors. Uveitis community talks about IL-10 by IL-6 in CSF for intraocular lymphoma. We have to come together to find disease-specific ratios of particular factors of pathological importance to walk around.
Yes, I agree. Yeah. We did a similar thing for IL-1B to IL-1RA. So one seems to be a protective, another seems to be. Yeah. So that ratio is something we worked for.
IL-610 is something we do very regularly for our uveitis patient to differentiate masquerades from inflammation and then go with mid-88 and all that. But this is the first step.
Yeah.
And my suggestion to you, Arka, is probably look at the change in the cytokine expression after fecal transplant. I mean, that would be the kind of the
Absolutely. We need to connect. Yeah.
We need to connect
the microbiome with the immune response. Absolutely. Yes. Very good.
Okay.
Chaitra,
finally.
all yours.
I don't think we'll ever stop talking. So next we go to the session, Retinoblastoma Trials and Tribulations. We'll have a lot of inputs from Dr. Kasturi as well for this session. And it gives me great pleasure to introduce Dr. Honavar. All of us know him really well. He's renowned and for a lot of the work that he's been doing, and also currently the editor of IGO and the IGO case reports. He's taken the journal to very, very great heights. He's also the director of medical services at the CFS group. He's the director of the Department of Ocular Oncology and Plasty, again at CFS Hyderabad, and the director of the National Retinoblastoma Foundation. So no one better than him to talk to us about how retinoblastoma outcomes can be optimized and if there is scope for us to do even better. Over to you, sir.
Thank you, Chaitra, for an introduction. Great. Can you see my slides?
Yes, sir.
All right. It's like opening new doors in retinoblastoma. When I was listening to the previous talk, and this is exactly how I was feeling, how to get out of it. You know, I was stuck because I'm a hardcore clinician and I can't do or think of basic research, but I can definitely tell you what is my wish list, and maybe you can work on it. So a few years ago, retinoblastoma had a very poor prognosis. 60 to 70% of children ended with enucleation, and life salvage was 2% in 1900s. Now we have totally reversed it to more than 98%. So there has been a dramatic turnaround. But can we do something about this 2% is the question. And also, can we improve eye salvage, which is currently hovering around 70 to 80%? Can we make it 90% plus? For that, we have to work a lot in terms of imaging, classification, customized focal therapy, newer forms of chemotherapy, and maybe multimodal treatment. In imaging, we have RETCAM, which is a fundus imaging under general anesthesia, wide field fundus imaging. We have FFA that can be done with RETCAM. We have OCT, which can be done under general anesthesia, which helps in screening, diagnosis, and monitoring response. The newer use of OCT is to classify vitreous seeds into epiretinal, subretinal, and various other forms of intraocular seeds, which has helped us design treatment for them. So imaging wish list would be something which is inexpensive, portable, which has a higher resolution, can be used in smaller pupil, and multimodal imaging, which can be networked. So if that can be worked out, then that would personalize imaging in retinoblastoma and also care of these children. In classification, we had staging and grouping. We have the international staging. We have international grouping, which prognosticates life and eye salvage respectively. What is new in classification of retinoblastoma is the AJCC8. For the first time ever in all forms of cancer, H has been introduced. Otherwise, it was TNM. Now it is TNM-H, H for heritability, where genetics has been brought into prognosis. So this is a very big change, I feel, and that has to be further optimized in terms of personalized prognostic factors. Genetic and molecular information can be used specifically for multi-drug resistant and metastatic potential of a kid. So that will help us prognosticate. In focal therapy, of course, the goals of management of retinoblastoma are always salvage of life, salvage of the organ, and salvage of function. In small tumors, focal therapy is the key, and our aim is vision salvage. We began with laser photocoagulation, which was done around a tumor, thus resulting in a large scar, vascular occlusion of the sort, visual field defect, internal limiting membrane rupture resulting in vitreous seeds, and it also reduces chemotherapy uptake. So it's no longer used, and we have shifted over to thermotherapy, which is a gentle form of inducing tumor cell apoptosis. It is done right on top of the tumor, and it classically prevents blockage of the blood vessels, and the scar is never larger than the tumor itself. It can be done in parafoveal posterior polar tumors as well. The higher magnification picture showing that blood vessels remain nice and patent. A newer form of TTT is chromophore enhanced or ICG enhanced TTT, which can be used over non-pigmented scars. For example, this was a recurrence over a non-pigmented scar treated with ICG enhanced TTT. So we should probably look at more such options of chromophore enhanced TTT and also image guided focal therapy with temperature sensitive colorimetric endpoint, because the assumption in when we do TTT is that we are increasing the intratumoral temperature to about 45 to 60 degrees centigrade, which induces tumor cell apoptosis. But we really can't know how much is the tumor temperature increase, because we depend on a clinical endpoint. But if we were to have image guided or thermal sensitive endpoints, which could be or may not be colorimetric, then we can further optimize TTT to keep it sub-photocoagulative. Sub-photocoagulative TTT is very important to do, otherwise it will cause all the complications that we encountered with laser photocoagulation. Further, there is scope for optimized PDT and chromophore enhanced thermotherapy with minimal collateral damage. There are already works that are going on in this direction. Multifunctional nanoparticles have been used with focused ultrasound and immunosynergistic therapy for retinoblastoma and also for melanoma. This is already in the experimental stage. In chemotherapy, there was a paradigm change in the management of retinoblastoma. It reduces the size of the tumor, and tumor always regresses towards its source of blood supply. For example, here the supratemporal arcade is the source of blood supply. Tumor has regressed towards it, thus freeing the macula and fovea very early in the course of treatment, thus optimizing vision. Shrinks the tumor, it resolves exudative retinal detachment, and thus enhances the scope of vision. Intravenous chemotherapy was the standard of care until 2000, but the prognosis with intravenous chemotherapy for higher grades of retinoblastoma was suboptimal. Then we brought in intra-arterial chemotherapy, which is super selective ophthalmic artery delivery of chemotherapy using a 400 micron catheter. That has changed the prognosis of retinoblastoma. But what is the scope for newer forms of chemotherapy? There are several ways of delivering chemotherapy. Intra-arterial chemotherapy, we use standard 3 drugs, topotecan, melphalan, and carboplatin, with dramatic results, as you see here, pre and post. Large tumors regress to very nice scars. But the issue with intra-arterial chemotherapy is that it is very expensive. Technologically, we are not challenged at all. We have very high rate of cannulation, but the cost seems to be the only barrier. It makes a huge difference in the eye salvage of group D and D retinoblastoma. So possibly we have to make the treatment less expensive in terms of cost of treatment for intra-arterial chemotherapy. And for further accuracy, we can probably look at robotic cannulation, which is already a reality in other subspecialties. So in ophthalmology, this is not coming yet, but there is some scope for a rapid cannulation of ophthalmic artery. Otherwise, interventional radiologists take a while to cannulate or get into the ophthalmic artery. Sometimes they're not successful, but this way of doing it may be more helpful. For intraocular seeds, there is a new classification. We used to call them all vitreous seeds earlier. Now we have further categorized them as classic vitreous, prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal, and even intracameral, we have depository and infiltrative seeds. For all these, we use intraocular chemotherapy. Now, intraocular chemotherapy initially was in the form of melphalan. You can see very nice effects of melphalan. These 3 or 5 vitreous seeds are completely gone. But what we started to realize was that with melphalan, there is retinal pigment epithelial atrophy and also the higher incidence of cataract, uveitis. It also needed multiple injections, weekly injections, and retinal toxicity. So we have further customized this by moving over to intravitreal topotecan, which is a gentler form of intravitreal injection, which is given 3 weekly. So it is spaced out injection, not needing weekly general anesthesia. Works beautifully well. You can see focal vitreous seeds gone. You can see diffuse vitreous seeds completely calcified with intravitreal topotecan. And we have been using it for refractory seeds, we use combination of topotecan and melphalan. So what is currently new about intraocular chemotherapy is that it's being used for anterior chamber seeds. Intracameral topotecan is used for anterior chamber seeds. As you see here, anterior chamber seeds gone with intracameral topotecan. 5 microgram is the dose that is used. And also further extended uses for subretinal seeds, which were earlier lasered. Now with just intravitreal injection, these subretinal seeds go away. So possibly there is a scope for using intravitreal chemotherapy for smaller tumors, if not for larger tumors. This is again a bunch of subretinal seeds gone without laser with intravitreal chemotherapy alone. So we think that RB seeds have been conquered, but there is further scope for customization by using epibulbar drug delivery systems, drug depots, which is called chemoplaque, which Dr. Gali has already put into trial, intraocular target therapy and gene therapy. This is the trial that is registered on topical topotecan episcleral plaque, which is called chemoplaque, and there is scope for further improvisation of this technique. Following enucleation, we still had about 20 to 30% mortality. Then we came to identify histopathological high risk factors that govern this mortality. So all patients with histopathological risk factors currently receive adjuvant therapy, and it definitely helps because it reduces the chance of mortality from 24% to less than 4%. That makes a survival benefit of 20%, which is very good. It was evaluated in a multicentric study and that was accepted. So enucleation is not the end, but there is scope still for risk stratified adjuvant therapy. All children need not get chemotherapy because we realize that only a quarter of them who have clinical risk factors, histopathological risk factors, develop metastasis. So 75% of children are receiving adjuvant therapy, whereas they don't need it. So there is a scope for identification of risk and making it really crystal clear as to which category of children would actually need it and would benefit from it. Regarding genetics, I think it's very well worked out, genetics of retinoblastoma. There is nothing much to talk about except the fact that liquid biopsy is coming in a big way. Use of aqueous as a surrogate measure for analysis is supposed to be more effective than using blood. This is a study by one of the groups from California. And there is also possibility of using non-invasive pre-implantation genetic testing assisted reproductive technology. That means that you select out a particular embryo which does not have the mutation and then implant pre-implantation screening that will help eradicate retinoblastoma in families altogether. About parental screening for children with retinoblastoma using apps. There is a scope for AI-based analysis of fundus reflex as a predictor, thus ruling out false negatives. So there has been a lot of work on life salvage, eye salvage, and vision salvage in retinoblastoma, which has taken us to about 98% life salvage and about 60 to 70%, maybe 80% eye salvage. So with all these personalized medicine, we have a scope for further improvement. There's definitely scope for optimization of care and prognosis. So possibly this is the way to go. Thank you so much.
Thank you, Dr. Amavat. That was a very nice overview, very well summed up, and also happy to see that the problem portion has reduced so much that we don't have too much to deal with, but we'll still discuss some solutions we have for that little 2 to 10% that you indicated there. So Chaitra, should we go ahead to the next talk? Because you said the time is a little short.
I think
so we can discuss both of these at the end. Together. Yeah. Okay.
So the next would be, again, novel and targeted treatment solutions for RB by our team, Raksha, Arko, and Gagan. Over to you guys.
Raksha, you can go ahead first.
So is my slide visible?
Yes, go ahead.
Okay, great. Okay. So thank you, Dr. Munawar, for outlining the current management of retinoblastoma. So taking the discussion forward, I would like to mention what challenges one might face in the current scenario. Okay, ma'am, slides are not moving. Just a moment. Okay. So The challenge number one is the disease itself. So in this project, which I did when I was with Dr. Shields at Wills-Eye Hospital, we studied 554 patients who received chemotherapy over 20 years, right from the beginning of intravenous chemotherapy for the management of retinoblastoma from way back 1994. So over 20-year period, 554 patients had received chemotherapy. And one of the most evident conclusion that was drawn was that the eye salvage rate with just chemotherapy alone in group E eyes was a meager 32%. So group E eye, as you can see in this picture, it fills most of the vitreous cavity. And when a tumor is so avascular, there is no scope for treatment with intravenous or intraarterial chemotherapy because the drug delivery to this avascular tumor is very minimal. Group EI can also present as a pseudo-hypopyon, and again, the drug delivery system that is currently available may not deliver enough amount of chemotherapy to this part of the eye. Group EI, again with neovascular glaucoma, which we studied in this particular project, we saw that despite careful management of all these eyes, out of the 37 eyes, only 21 eyes could be, 21 eyes had to undergo secondary enucleation, which is about 60% of the total eyes studied. Group E eyes again can present as this preseptal cellulitis, which when given chemotherapy can turn into a thesical eye where there is no scope for either vision salvage or eye salvage. Number two challenge is when the intraocular retinoblastoma progresses to extraocular retinoblastoma. So orbital retinoblastoma has a multimodal management which involves 12 cycles of high-dose chemotherapy, followed by enucleation or exentration, followed by orbital radiotherapy. Now, this is a very prolonged treatment, and we need to examine the child at very frequent intervals. Also, this high-dose chemotherapy can cause a very high number of systemic side effects. So then failure to compliance is just one of the problems. But what happens is invariably most of this orbital retinoblastoma can have intracranial extension, where not only there is no vision or eye salvage, but even life salvage becomes an issue. Number three challenge in retinoblastoma management is the atypical presentation, most commonly the diffuse anterior retinoblastoma, where in this publication that we did, here we could salvage this eye, but as you can see, it's a very difficult type of the disease to treat. You see that the retina is absolutely clear. There is no retinoblastoma there, and the tumor is confined to the anterior chamber, the angle of the anterior chamber, and delivery of intravenous or intraarterial chemotherapy becomes very problematic. These eyes can be saved by using periocular intravitreal topotecan. However, this again takes very long duration of compliance from the patient side, patients from the doctor's side. Number four challenge is complications of the treatment. As we all know, initially EBRT alone, that is extra beam radiotherapy, was the sole treatment for radiotherapy. However, with the introduction of chemotherapy, this EBRT as the primary treatment has come to an end. However, EBRT is still used in some cases of orbital retinoblastoma or other indications post enucleation. As we see, this data is from long time back when EBRT was the sole treatment. There was a high rate of mortality of up to 30% due to secondary cancers. Not only that, EBRT can also cause contraction of the orbit. And regarding chemotherapy again comes with its own side effects, starting from systemic the changes in the blood parameters, but as also some second cancers in germline mutation, of which leukemia is one of the most common due to direct toxicity of the chemotherapy into the bone marrow. So this is one such patient who had unfortunately 3 cancers. The child had bilateral retinoblastoma, underwent chemotherapy, underwent orbital radiotherapy, ended up having osteosarcoma, was treated for osteosarcoma, and finally the child presented with soft tissue sarcoma of the cheek. There are also certain complications associated with focal therapy of TTT cryo, where they leave can be retinal scars, periocular and intravitreal injections, which can cause, theoretically, there can be implantation of seeds in the extraocular part of the eye. And also there can be some perforations if not injected carefully. Intraocular chemotherapy, all the very few side effects. It can sometimes cause fibrosis of the ophthalmic artery. And once the ophthalmic artery is fired, of course, there is no salvage of vision. Number 5 challenge is the genetics, as Dr. Honavar already discussed. Although RB1 gene is the only gene that is mutated in retinoblastoma, germline mutation can cause multifocal bilateral retinoblastoma that presents at an early age, is very aggressive, shows a high number of recurrences, and is quite resistant to the usual form of chemotherapy, may sometimes require high dose chemotherapy. So number 6 challenge is the logistics and finance involved in the treatment of retinoblastoma. So although intraarterial chemotherapy is now known to cause high amount of eye salvage in group D and E eyes, it involves a lot of charges, including the cath lab charges, the general anesthesia charges, the chemotherapy charges, and of course, not one cycle is enough. The repetitive cycle just adds to the burden of finance to the family. Now, this is a beautiful article which is yet to be published that we did of impact of COVID-19 nationwide lockdown on retinoblastoma, where we studied 476 eyes of 326 children. Here, we just showed how non-compliance in retinoblastoma can affect the whole disease management. So this is a child in picture A that you see presented with group E retinoblastoma, who did not follow up for 10 months due to COVID and the nationwide lockdown, who ended up having orbital retinoblastoma, as you see in picture C, and unfortunately, the patient succumbed to the disease. Similarly, yet another child where in picture A, you see a regressed stable retinoblastoma scar, which due to non-compliance and non-follow-up during COVID times led to a huge recurrence, and the child required intraarterial chemotherapy, thus adding to the financial burden. So why this is important in this particular scenario is that since retinoblastoma involves very frequent examination under anesthesia, very frequent injections and chemotherapy and radiotherapy, the duration of the treatment is prolonged. So any disease for that matter, especially retinoblastoma, there's always a need for newer therapy. And from here, I pass on the discussion to Dr. Arka and Dr. Gagan, who have been doing some amazing research in retinoblastoma, and hopefully we will get to see the end of it and some amazing results will work out.
Thank you, Raksha. All right. So Raksha has very nicely pointed out that we are still in a job and we still need to do some work to find some new drugs and stuff. Now, what I'm going to talk about today is how we have gone about trying to identify what are the molecular pathways that need to be targeted so that we can address some of these unmet clinical needs, which are essentially increase the efficacy of the currently available treatments and reduce bystander toxicity of these current treatments, of these current chemotherapies. So what we did was we did an integrated biology approach where essentially we used both gene expression, we used metabolomics to look at metabolites secreted by the tumor. We looked at all the protein level changes that happen within the tumor, and we integrated all of that. And that is what led us to some of these new pathways and new genes that we've gotten. So I'll quickly take you to what we found. So one such gene that we found is called hexokinase 1. And if you look at these immunohistochemistry slides of group D and group E tumors, the brown tells you that there's a lot of that protein. So you can see that E2F, which is the transcription factor that essentially causes the tumors to aggressively proliferate, that is upregulated, which is not present in healthy control pediatric retina. But hexokinase 1, which is present in the healthy retina, is not present in the tumor tissue. And this is classic, where you can see that there is some healthy retina left in this eye, and that is staining properly for hexokinase, but the tumor tissue doesn't. So what does this gene do? So hexokinase is the first step of glycolysis. It's the enzyme that catalyzes the first step of glycolysis. So essentially, it can reprogram the metabolic circuit within a cell, and that may be a tumor cell, a healthy cell, whichever. So what we've discovered is a new player in the tumor cell metabolism, which possibly could help us control the tumor. So if you look at some of these results, where this is a 3D tumor done in vitro. So this is a retinoblastoma cell line called the VERY-RB1. When you put back the retinoblastoma gene into that, the tumor can no longer grow. If you put E2F2, which is the transcription factor that gets released in absence of retinoblastoma, the tumor becomes even larger. And when you use hexokinase 1, you see results that are similar to putting back retinoblastoma. So this is exciting, but what is getting reprogrammed? So when we talk about metabolic reprogramming, it's all about producing energy. So now the tumor cell wants to produce a lot of energy so that it can grow rapidly. So if you look at these cells, so these are the grape-like clusters that the retinoblastoma cells make. And you can see this green, green is the staining for mitochondria, which produces all the ATP in the cell. It's the powerhouse of the cell. When you add back retinoblastoma gene, then these green signals go down. When you add back hexokinase, you see the same thing. The green signals go down. But if you remove hexokinase even further, it's already low in the retinoblastoma cells. If you remove it even more, you see the green signal go up a little bit more. So what this tells us is that the tumor cell is more dependent on mitochondria and increases the amount of mitochondria within itself to produce more energy. So how is it producing the energy? What are the fuels that it is using? So it turns out, so these are fuel assays that we have done using a technique called the seahorse technique. Now, energy is produced through the mitochondria using the electron transport chain. And prior to the electron transport chain, these electrons are produced by the tricarboxylic acid cycle. So this is all stuff we read in 6th and 7th grade. So glycolysis, glucose goes in. Now, apart from glucose, there are other energy sources, glutamine and fatty acids. So what these retinoblastoma cells do is they start using fatty acids more than they use glucose. So they use more glutamine as well, but fatty acid dependence is huge in these cells. And the normal retina, it uses more glucose and not as much fatty acids. So the reason for that is that when you digest fatty acids to make energy, you produce 129 ATP per cycle. When you're using glycolysis, you produce only 2. And then when it goes into the electron transport chain, the total is about 34. So obviously, the tumor is very happy eating a lot of fats and producing far more energy than the regular retinal cell would. So this brings us to this unique pathway that we found, where retinoblastoma actually controls hexokinase, and hexokinase controls the energy sensor in the cell, which is AMPK alpha. So to take you further, I'll invite Gagan now to talk about the translational aspect of it. Gagan, you have control.
Yeah, thank you. Yeah, it's working. So see, Dr. Kasturi, Dr. Honavar, and Raksha can really identify, at least all of us, when we treat retinoblastoma, we deal with some mortality. And this is one of the conditions where we have mortality hand. Otherwise, in ophthalmology, we don't see deaths. We may see loss of vision and other things. So anytime you get a patient of retinoblastoma, you just wish before you see the patient, not another D, not another E, ABC will take care. But that's a wish we have at hand, that the patient should not be in an advanced stage. So the moment ARCO came up with this and we've got the preliminary results, as a clinician, you also, okay, how can I use it for patients? How can I help this information make a difference? So when I told ARCO, okay, what next? What do we do next? How fast? So he said, no. It's a long journey. You have to go through a grind. Other work has to be done before you actually do something. So I'm going to present that other work part. After reaching here, what do we do next? So we came to a conclusion that if we target AMPK, we will be able to regulate RB tumor, means we will be able to shrink down the tumor. So how do we do that? We need some molecule, some drug to do. So one of the molecules what we can use is ICAR. So ICAR will activate AMPK, and dorsomorphin is an inhibitor. We are using dorsomorphin only to complete the experiment. It does not have any role in the treatment here. So going further, what we do is, if you see here, this is ICAR, and this is the retinoblastoma cell, very one cell line. Once we treat them with ICAR, you can see the retinoblastoma cells are dying. So it indicates that this is going to kill retinoblastoma cells, whereas dorsomorphin does not. And if you come onto this part of the screen, onto your left, this is a tumor spheroid, which we showed earlier. It's a model to mimic the retinoblastoma tumor. So when we give topotecan, you can see the shrinkage which is there in the tumor spheroid. It's like a nuclear bomb because it's a anti-cancer drug. It really acts fast and it's destroying all the cell. In ICAR, you can see there is a reduction in size, but it is not as much as with topotecan. So it's working, but it is still a little less effective. So once we have this, we also think of terms that, okay, how can we enhance the effect of ICAR? Or can we combine topotecan and ICAR? How does it work? So to find out an answer to that question, we do something called checkerboard assay. So you can see here, we are using topotecan and ICAR. And in a checkerboard assay along x-axis and y-axis, you have a decreasing dilution. So you go and calculate an FIC1 value, which is here. And on your right, if you see that FIC1 value will tell you whether the drug is a synergistic, additive, or antagonistic. So in case of topotecan and ICAR, FIC1 value is 0.75, which indicates these drugs have an additive effect. So we can use both of the drugs in 50% of dosage to have an effect. So basically, the topotecan dosage comes down by half, the ICAR dosage comes down by half. So to go further now, this is all in lab. So we have done different experiments. What next? Next is obviously we need animal. So we use a rabbit model here. In a rabbit xenograft, we immunosuppress the model, immunosuppress the rabbit by using cyclosporin A, and then we inject the very one cells into the eye. And after injection, it will form the tumors. Once the tumors are formed, we treated it in 4 groups. So group A was untreated as control. Then we had treatment with topotecan, treatment with ICAR alone, and treatment with topotecan and ICAR as a combination, which we called the additive combination. And after this, at around 70 days, the rabbit is sacrificed and histopathological examination is done. So these are the results in the rabbit experiment. This first one is the retinoblastoma tumor being formed. This is an OCT of rabbit. And when you use topotecan in half the dose, you can see the tumor shrinks in size, but it is not completely gone. Whereas topotecan in the 100% dose, the tumor is gone. If we combine ICAR and topotecan, you can also see that there is a near total resolution of the tumor, though not complete in this case. But the interesting part here is, look at this histopathological cut section. You see that the retinal architecture is preserved. This is topotecan and ICAR. And this is topotecan alone. You can see, though the tumor has been killed, it has also caused plenty of other damage, and the retinal architecture is also getting damaged. So this really brings us to the thing that, okay, ICAR will help us protect the retinal pigment epithelium for the damage, which was shown by Dr. Honavar also in case of melphalan, what he showed. So it will kind of reduce the toxic effect of chemotherapy. And this is what you can see here is untreated retinal pigment epithelial cell. And this, when we treat with topotecan, you can see the damage topotecan is causing to the RPE cells. So this is a toxicity which we want to reduce to make treatment better. And going with this, we also checked out with another molecule. So we have something called cationic antimicrobial peptides. They are naturally acting peptides which work against the bacterial cell wall. So they are negatively charged, and they are going to work on the cell wall which is positively charged. So and then kind of destroy the cell wall and cause cell lysis. Now, interestingly, RB cell retinoblastoma tumor also has a positive cell wall. the cell wall has a positive charge. So the cap can work against retinoblastoma. And we devised an experiment to check for that. And if you see here, these are the untreated retinoblastoma spheroids, a kind of what we shows. These are spheres and these are retinoblastoma tumor with topotecan. Again, they are all nuked. They are all disrupted, gone, and it's like everything gone. But here we are seeing again with HC3 and HC5. These are two prototype cap molecules where you see the tumor is slowly shrinking in size. And we did further experiment where we found that this can also work synergistically along with topotecan. That was additive. So this again gives another selective treatment targeting retinoblastoma cells, and this one will spare the retinal pigment epithelium. So, the chemotoxicity will come down. So these two drugs basically answer some of the questions which we had earlier, that can we sensitize the tumors to, can we, prevent the toxicity of chemo drugs to other medication, and that we can see that these drugs are helping us in doing that. And can we also personalize the medication? So, we can use these medication in different combination based on certain other factors and have an additional thing which is going to work there. Most important here is what this presentation when me and Arko are doing to Raksha is the point that we are able to do this because there's a constant discussion and exchange of ideas between us, the clinical team, and the research team. So, we have lots of questions. We see something unusual, we discuss with the research team. They find some finding, and then we see, okay, how can we check it in clinical, and how really we can, bring it down to clinical practice. The whole thing here would be that if we want to personalize medication, a very intense collaboration between the clinical and research team is required to really help these patients have a better life and better survival. Thank you.
Wonderful.
Over to
thanks, Gagan. And I also want to thank my student Vishnu, who's been in charge of doing all this work, and it's being continued by other students in the lab, particularly all our past retinoblastoma consultants as well, who have contributed to this work. So I think with this we'll end.
I think we have some time for discussion.
Yes.
I mean,
so
we're
now
overshooting, but we
have
need to
discussion
Dr.
on
Kasturi,
retinoblastoma as a whole.
On our
I'll just add something like so beautifully Dr. Santosh and Rachna and Gagan has mentioned. But I'm very thankful to Dr. Chetra for bringing up this topic, because we know that this is such a common pediatric intraocular tumor. And if we see amongst all the cancers, like it is, I think it constitutes itself for 11%. But I just like to add some point, because as Santosh has mentioned, Raksha has mentioned that, yes, we know the gene, the germline mutation in the RB1 gene, but sometimes we also not know that 2% of unilateral non-familial case, they have a normal RB1 gene, but they have some multiple copies, like abnormalities in the oncogene mutation, that is the MYCN. So recently there has been talk about the MYCN oncogene, and now the drugs are basically targeted to all the oncogene. I think Arka has mentioned about the MDM4, like MDM4. But recently I have gone through, I think 2 years back in one of the ARGO meeting, people were discussing extensively about the clinical grade oncolytic adenovirus, which really works. Actually, they're still in the animal phase, but there has been lots of discussion about this VCN01 and also about the different types of the targeted therapy. And Santosh has very nicely mentioned about the liquid biopsy, because retinoblastoma is the only cancer where we treat on the basis of clinical diagnosis. We usually don't do a biopsy for treatment of it. But now with the molecular biomarkers coming out, lots of studies are going on the biofluidics. I have a small question to Arka, like, it was very nice hearing about the ICAR, because when we talk about ICAR, we know that it is basically the body itself produces naturally, and which you have already mentioned that AMP activated protein kinase pathway. But I have been knowing that it is basically used for different types of cardiac ischemia, and they regulate the blood flow. So do you think that this is the same mechanism where they're preventing the toxicity of topotecan by increasing the blood supply? This is what, do you think it is working in that mechanism?
No, I don't think here it's about increasing blood flow per se. The way it works is, so AMPK is a energy sensor. So essentially you can consider ICAR to be similar in function to metformin. However, it is far more effective because it's a direct analog, whereas metformin works through other protein members to exert its effect. What ICAR essentially does is it turns this sensor on. Once this sensor gets turned on, it reprograms the tumor cell's metabolism and stops it from eating more fatty acids. Now it has to go back to eating more glucose. So now its energy gets restricted, which is why once its energy gets restricted, it's no longer has the same growth potential, even if it has all the mutations that you talked about. That is the beauty of this approach, is irrespective of all the different mutations that you have, these sorts of targets, because the metabolic targets have to be reprogrammed if the tumor is to grow. Even when we say that MECAN is going to amplify the tumor, ultimately the tumor has to have energy and amplify itself. So that energy circuit changes as soon as you have a tumor. Now, if you attack that energy circuit, irrespective of the mutation that you have, you will still see a beneficial effect.
Thank you. And what about the biomarkers? What is the role of the liquid biopsy? Like nowadays, people discuss a lot about liquid biopsy. So what do you feel that what are the specific biomarkers you feel that will help as a targeted therapy towards retinoblastoma?
Yes, so I think liquid biopsy is definitely the way of the future, simply because you don't have to go get the tumor out and then do a. So, but the challenge that liquid biopsies are facing, and it's not just retinoblastoma, in many different cancers, is the source set of mutations are different in different cancers. So here also, you brought out very elegantly the point of unilateral retinoblastoma, where the germline mutation isn't necessarily present. And you got the de novo mutations. And in a lot of cases, even in our cases, we do have patients included in our study cohorts where there is no retinoblastoma mutation. So you have amplification of other genes. Some of them have MECAN amplified. Some of them have a bunch of other genes which are amplified, not MECAN. But the end result is the same, where the cell starts amplifying more. So with liquid biopsy, the challenge is that we need to have our input data set cohort to broaden. So apart from RB, apart from MECAN, apart from KLF4, what other things should we look for? That is the bigger question. And I think the role of ethnicity and catchment areas, those do play into that. So I think ideally, what would be useful clinically would be a combination of the genetic marker as well as these expression markers. So something like AMPK or hexokinase, these would be expression markers. And downstream of these, there will be metabolites. And I think some of those metabolites will come out. We are working on some of these, which we found to be very faithful. They go up when the tumor goes up, they go down when the tumor regresses. When the tumor comes back, they come back again. So those kinds of markers, I think, and we are trying to do that from tiers. So when we are ready with it, then hopefully those would be useful in clinical practice.
Thank you, because now even retina people are using lots of adenovirus treatment. So how do you think that the role of this oncolytic adenovirus?
Yeah, I think oncolytic viruses is very useful. And I think the simplest from gene therapy point of view, I think Dr. Honavar mentioned it very eloquently. We can simply express RB. So if you put RB back, see the normal retina, if you put back RB, it's not going to have any effect. Whereas the tumor cell, if you put back RB, it'll stop the tumor, it will change its metabolism, everything, and you'll get the therapy. So, P53 therapy is available in China for head and neck cancer. It's essentially RB and P53 work in similar ways. So the same RB gene therapy, if we can do, that will be something interesting to try out right off the bat. The VSV is another one, the oncolytic virus, vesicular stomatitis virus. So that was first tried out in sarcomas, and it worked quite well. So, but it didn't come to mainstream because of the added risks of it remaining there and then reactivating later and then killing non-tumor cells also, something like chemo or radio. But the effect is so long-term in terms of gene therapy, you have to be extra careful.
Thank you.
Dr. Honavar, do you want to make any comments?
And this, viral vector therapy has been going on. The experiments have been going on for the last 12 years, but it's not really progressed, mainly because the way it is to be delivered is intravitreal injection. And for small tumors, we never have a problem. Group A, B, C retinoblastomas, we're absolutely fine. It is question of D and D where intraocular injection would be a very, very high risk for extraocular extension of tumor. So we have to find a novel way of delivering this into the eye without having the risk of extraocular extension.
Right. Very good. So, Gagan, anything you want to add before we move to the next? Chaitra, could you ask our other panelists if they have something to say?
Yes, if anybody has anything, ma'am, otherwise we'll go to the next. We've actually, it's supposed to be closing session now, but we have a very, very interesting one coming up and very topical as well. It's on ocular immunology and COVID. I'm sure there's going to be a lot of insights by Dr. Vishali on immune-mediated ocular inflammation due to COVID and the vaccination itself. We're seeing a whole lot of patients coming in with sequelae due to both the disease and its prevention in the form of vaccination. Over to you, ma'am.
Thank you, Chaitra. And thank you, everyone, for this very, very interesting forum. So the topic Chaitra has given me about immune-mediated inflammations due to COVID and vaccinations. So let's look at what does COVID do. In a nutshell, you do need ACE2 and you need TMP, RSS2, receptors for the virus to adhere and then get entry into the cell and cause whatever it does. Now, both the receptors, after multiple reports of them present, absent, but eventually it has been beautifully shown that these receptors are expressed in neuroretinal cells, mainly ganglion cells, inner plexiform, inner nuclear, and photoreceptor outer segments. We also know that RPE has toll-like receptors, and it could be the one which again might get involved by the COVID virus. So COVID produces three kinds of changes all over the body, though we are understanding more and more. Basically vascular, inflammatory, and neuronal. And over a period of time, as we understand, is the inflammation is the key, and the other two changes may be a part of inflammatory cascade that it is inducing. When we talk of vascular and neuronal changes, we did actually a prospective trial, cross-sectional, where we, went to the COVID ICU where our COVID patients were, and we just screened them, and of course, doing all the whatever the requirements were, we screened these patients. And then we followed them up during the convalescent phase. And for convalescent phase, the hospitalized patient, that is 73, were screened 2 weeks after they were discharged. And for home isolated, we screened them 17 days after COVID testing. Interestingly, we did not find any retinal lesions or inflammations which could be attributed to COVID-19 during the acute phase. No retinitis, no necrosis, no inflammation. 5 patients, which was 5% of the total, during the convalescent phase had cotton wool spots, which may or may not be associated with retinal hemorrhages. And they had no other retinal finding, no visual symptom. And these spots actually appeared 30 days from the day of the COVID diagnosis. These 5 patients did had associated comorbidities like diabetes, hypertension, anemia, coronary disease, and kidney disease, but none of them had features other than the cotton wool spot, which were suggestive of any disease. Now look at this patient. These are the cotton wool spots which were actually seen. These spots were seen much later, 30 days or so, and they appear like this. And this is in the inner retina, which is one of the layers predicted to be involved. When we published it, we called it COVID microangiopathy like HIV. And of course, on OCT, these findings that show there is vascular events. You can see the area of non-perfusion, and which was not, of course, a one-time event, as I will show you. This is an example of a 73-year-old man. When we scanned him in the ICU, he was doing fine, nothing in the retina. But 44 days after COVID-19 diagnosis, the cotton wool star appears in the left eye and the right eye is normal. 2 weeks later, we see 2 new cotton wool spots appearing in the right eye, which was normal, and the left eye is kind of resolving cotton wool spot. So is COVID inducing an ongoing insult? This is something, we would love to find out. And does it predict anything in the brain? What exactly these cotton wool spots represent, we don't know. We thought of thrombotic microangiopathy, but seems unlikely. Most plausible seems to me is the immune mediated, because these are fresh lesions and cytotoxic T lymphocyte is probably infiltrating the ganglion cell and plexiform layer. These are definitely not direct viral infection, and enhanced damage by the virus in the retinal microvasculature in presence of systemic comorbidities was something which we considered. So we wanted to a longitudinal follow-up on these patients, which we did. And over the longitudinal follow-up, we did find that these would resolve over a period of 12 weeks on an average, leaving just few, changes in the retinal nerve fiber layer. So we could not find any systemic correlate. It was self-limiting. We even did MRI in a couple of patients because many studies were suggesting that if you see these cotton wool spots, probably it means there is some neuronal damage in the brain, like we could not find anything. So what we reported was that they disappear, and to corroborate our results, there is recently a study in BGO as well, where in Singapore, they recruited patients. They did the OCT angio for the patients who had COVID and those who did not have COVID. And they found that the microvascular signs are related exclusively to COVID. So it's safe to call it COVID microangiopathy. Vein occlusions, we all know the only implication is this is the venous occlusion that happened in a 28-year-old within 8 hours of receiving Covishield vaccine. No risk factor, but I think the only marker is if you catch it early and it's not fully developed, probably there is a role of steroids. So I don't have honestly the biomarkers to suggest which are elevated, but going by what is available in the rest of the body, high dose steroids may help during the very early stage. However, if you see patient when it's already formed, of course, anti-VEGF. AMN, that is macular neuroretinopathy, and paracentral acute middle maculopathy, these kind of lesions, they actually just represent ischemic insult. They have been reported, and I would like to show you this patient who's a 50-year-old man, and he was in our ICU for COVID pneumonitis, and visual loss happened on 5th day. But we saw him after 2 weeks after he was discharged. So there was hemorrhage in the left eye, and there were these kind of white lesions which have been reported in this case report as punctate kind of the lesions, as you see here. Now, what do these lesions represent? We did the fluorescein, and you can see these lesions are actually punctate hyperfluorescent. And on OCT, what we found was these lesions, which is due to ischemia. But interestingly, when we did the OCT through the lesions that were punctate, there is a loss of ellipsoid zone, and you can also make out there was inflammation in the eye. So it's a kind of photoreceptoritis that it is producing, and I would rely on my imaging biomarker to see this kind of inflammation, and I would treat it with my anti-inflammatory agents. In the same patient, we also found the new vascularization, which is very different from the new vascularization we see. It's more of a non-sprouting intussusception new vascularization that has been reported in 2 animal models back in 2012, and mostly in viral inflammations in rats. So I'm going to scan more of my patients for this. COVID as well as vaccination both are inducing either the new inflammations in the choroid RPE complex, or there is reactivation of the old one. Now here I could find that like we have a series of patients, and I collected the vitreous, and it was the TNF which was elevated. So if I don't find a cause and I'm treating, I know anti-TNF is the one which is going to work, which has now become my first line of therapy for COVID-induced, whatever it is, choroiditis. This is within 24 hours of the injection. You can already see the lesion starting responding to therapy. Many of our patients who were, quiet for almost 2 years and developed the vaccine, they have started developing these new lesions following vaccine. So I think this vaccination is kind of, triggering some kind of autoimmune response somewhere, and these lesions are coming back. And very interestingly, don't be in a hurry, go off the comment, but teleconsult was a major culprit besides the vaccination in inducing the reactivation, because on teleconsult, people will in a hurry to stop biologics or immunosuppression, which actually we reported in VGO that resulted in very high number of patients who came back to us with relapses. Just to show you the last case and how the phenotype keeps on changing even in the same patient. So when we talk of personalized medicine, it is not about, I know it's about genotype, phenotype, but even in the same patient, the phenotype could change from time to time, and you may have to customize your therapy based upon the changing or evolving phenotype. Now, this patient I had seen in 2018, and he had a small PED which was there, and we did not do anything. The fluorescein was done, so everything was normal. Then he develops COVID. And 1 month after COVID, he was on oral steroids because of deteriorating vision. And he just came to us with a second opinion of query retinitis. So I'm sorry, this is kind of not animated. If I can, I'll just remove it. So this is what it was. You can see there was this retinitis, which was on OCT. You can see it was kind of full thickness retinitis. There was definitely vascular involvement, vasculitis, and there was some retinal hemorrhages as well. The left eye, he had undergone atrophy of the retina, and you could see there was total atrophy of the retina, and which was very well appreciated on autofluorescence. So I thought it was probably COVID retinitis, because to me it looked like SSPE or other RNA viral infections that I see. So, in my mind, it was COVID retinitis. So I took a tab, did RT-PCR. COVID was negative. So I honestly did not know what to do. And during the workup, his blood culture showed staph hominis. Now that comes a problem, because was it endophthalmitis? Anyways, we treated him for endophthalmitis because we couldn't do anything for COVID. So during 3 weeks, the lesion starts responding, but in the left eye, there is a lesion. Again, we pushed in more antibiotics. And after few weeks, this is what we end up with. If you ask me today, when I'm looking back at this, it was not infective endophthalmitis, and probably antibiotic didn't do anything. Probably the viral retinitis resolved on its own, but I would have loved to have biomarkers at that point of time as to, what it could be. Did fine, lesions resolved, we were kind of okay with it. Till 8 months later, he comes back with the recurrence of inflammation in the right eye and also in the left eye. Now, what he has is diffuse vasculitis, which was not there before, which is something, it looks like autoimmune to me, and same is in the left eye. So again, we did everything negative, and we started him on oral steroids and azathioprine, to which he was kind of responding. But the day, that is a month later, when the steroids were reduced, he comes up with synovial thickening in the joint, in the right hip joint, which is suggestive of inflammatory arthritis. Now, whether this vasculitis is a part of multi-organ inflammation secondary to COVID or not, I think it is. So he was again changed to methotrexate, and now we have to see the response. So to conclude, COVID-induced inflammations are evolving. It's very important to characterize the clinical, because we don't even understand the phenotype in COVID, the big challenge, the imaging and biological markers, so that, we can actually evolve some kind of targeted therapy in these patients. Thank you once again, Chaitra, for your kind invite.
That's a good compilation, ma'am. I think you've covered almost everything. And of course, we're all very alarmed by these, different presentations that sometimes we don't have a clue as to what's going on. And then we do need a lot of investigations to finally figure out what's going on. And to present a little bit of that work on the ocular surface disease that we've done, over to Pooja, Swami, and Sharon. And we will definitely be having some discussion on this session just after they finish their talk.
Hi, good evening, everyone. So I'll be starting off the presentation from the three of us. So I hope my slides are visible.
Yes.
Just give me a minute. Right. So the talk today is on discussing the status of the SARS-CoV-2 specific pro and antiviral genes on the ocular surface, and discuss probably the insights into susceptibility risk and possible preventive measures. So the COVID-19 pandemic caused by the SARS-CoV-2 virus has really changed our lives and the way we look at our patients. And we do know that the cellular axis, and it was so beautifully described by Dr. Gupta about how the SARS-CoV-2 depends on the binding of the viral spike protein S to the surface receptor on our any epithelium, be it the cornea conjunctiva of the ocular surface or the retina. And the priming of this is done by the TIMPRESS2 and the cathepsin L. And what we've seen is that the cornea and the conjunctival epithelium has obviously large areas of mucosa, which make it a very good area for the viral entry. The ACE2, the TIMPRESS2, and the cathepsin L are predominant in the cornea, the conjunctiva, and of course the airway, because that's the primary area where the virus enters, and thus making them very good potential routes for viral entry and transmission. We do know that modulation of the ACE2 expression and its downstream effects have been reported in lung disease. But the ocular surface-related SARS-CoV-2 mediated immunopathology is poorly understood, and that's what we're going to discuss today. So this is a sort of a life cycle of the virus and how it enters into our cell, the binding, the entry, the replication. And what we need to highlight here is that basically the key players in this fight, when we are talking about trying to see how to stop this virus, is looking at how it's entering and the priming of the virus, and the three, very important ACE2, TMPRSS2, and the cathepsinel. And how is the host response, or how do we fight this virus, which is mainly by the interferons, and interferon 1 induces the MIX-A or MIX-1, which is, as we know, an inhibitor of various viruses. So the aim of the study was to study the expression patterns of genes associated with SARS-CoV-2 attachment, entry, and the host antiviral response. And this was done across groups of healthy controls, eyes from COVID-19 diseased and COVID-19 recovered patients. And the second objective was to determine whether there's any molecular changes by topical agents which are available to us, like trehalose or chloroquine, and whether this could be used for ocular surface prophylaxis. So this was a cross-sectional study which we did after the ethics committee clearance, and the full globes collected during the eye collection, which were deemed not suitable for transplantation, were used in this. And of course, very strict precautions because of the COVID situation were used for all the eye collections. So once we had received these eyes, we dissected it layer by layer, right from anterior to posterior. So corneal epithelium, stroma, endothelium, conjunctival epithelium, and so on and so forth. And then the samples were stored at -80 degrees. Some of them were used for gene expression analysis for the mRNA levels of the various proviral host genes and antiviral response genes, which we talked about. And sectioning of the histopathology specimens was done, and immunofluorescence was used for specific proteins. So these are the results. So we break up our results into 3 or 4 parts. And the first is to see how the entry and priming genes of the SARS-CoV-2 are in the ocular tissues. So on the left side, the graph basically shows the ACE2 expression, the mRNA expression across the various layers or structures in the eye, right from the RPE and the ocular surface, including corneal conjunctiva. And it's compared to primary lung epithelium that we obtained. And the red dotted lines are just to bring your attention to the ocular surface structures like the corneal and conjunctiva. And what you can see is that the quantitative PCR exhibits higher expression of the ACE2 mRNA in the cornea and conjunctiva, okay, as compared to, is compared to the primary lung epithelium. On the right side, we're looking at the immunofluorescence of the various, the structures which we sectioned. And the green color is what is marking the ACE2. And it's very evident that there's intense localization of the ACE2 in the corneal epithelium and the conjunctival epithelium, as you can see. So these are in normal ocular tissues. When we look at our next marker, which is the TMPRSS2, same, we see a very high expression of the TMPRSS2 in the cornea and conjunctiva, as shown in this graph, the mRNA expression. And on the right side, again, it's the immunofluorescence of green color. And you can see that there's intense localization in the corneal epithelium and conjunctival epithelium. So no doubt there are a lot of localization of these very important structures to which the virus binds on the ocular surface mucosa, making it increased and very susceptible to the binding of the virus. Now coming to our host response. So the antiviral response by the interferons, we found, again, we looked across all the various structures through the eye, as discussed in the previous slide, and we found that there was definitely a high expression of the interferon receptors, but the gene which it induces, the MIX-A, which is actually a protective factor for our ocular surface, was much lower in the ocular surface tissues compared to the other ocular tissues. So it implies that there's probably a lowered protective response that we have. Now, when we go forward and look at a comparison of the normals versus a person who who is actively having COVID versus a COVID recovered eye. And these are the three columns of images that you see in the immunofluorescence. Then here the ACE2 is depicted by a red color and the mix A is in the green color. So I draw your attention to the fact that the ACE2 has pretty similar levels in the corneal epithelium, whether it's a control cornea or an active COVID-19 positive eye versus a recovered eye. But the mix A, which is our protective factor again, is much lower in the eye which was from a person diseased with an active COVID-19 disease compared to both the controls or the COVID-19 recovered eye. And just to bring it, highlight that a little more, we see that the mean immunofluorescence intensity, of course, was much lower in the COVID-19 positive eye of the mix A. So when we look at the access routes, so till now we were, again, talking about those same factors which are so important for us. Again, we find that here the TIMPRIS2, which is in red, and the cathepsin-L, which is in green. So the expression of both of these were much higher in the COVID-19 positive eye as compared to control and the COVID-19 recovered eye. So just if you can look at this image itself, it's so representative of what we are seeing. And this is just to reiterate the fact that the ocular surface seems to be so susceptible to the viral entry. And definitely once there's an infection by the COVID-19, there's a definite change as compared to a normal and or a recovered corneal tissue. So what happens? So this is in an ocular surface which is presumed normal. But when we have an altered ocular surface, for example, in dry eye disease, we wanted to know if there's any change from this normal protective mechanism or normal receptors that are available. And so we did this experiment of impression cytology, which we had collected pre-COVID time of patients of dry eye disease. And very interestingly, we found that in a patient with an altered ocular surface, like in dry eye, there's a definite increased expression of those three, the ACE2, the TIMPRIS2, and the cathepsin-L. And there is reduction in our protective interferons, the type 1 interferon. So definitely this altered balance could imply that it increases the susceptibility even more. So with this background, it didn't end there. We took it further to see if there's anything more we can do. And I invite Dr. Swaminathan to talk about this work further.
Thank you, Dr. Sharon. And one of our primary objectives is to find out whether we have any good prophylaxis for the ocular surface. And we chose chloroquine and trehalose based on their literature on how they would be beneficial in bringing about antiviral response. In the next slide, what you would see here is going to be an in vitro assay. We have taken human corneal epithelial cells and human alveolar epithelial cells and treated them with trehalose and chloroquine for a period of 24 hours. What you can see in the table is a representation of what you see in the graph towards the left is a significant reduction in ACE2, TIMPRIS2, and cathepsin-L can be seen by both trehalose and chloroquine. However, what was startling was trehalose was able to induce type 1 interferon, whereas chloroquine was not only able to induce, but it actually showed a reduction in the type 1 interferon expression. So we thought, in order to go further to test the efficacy, we chose trehalose. And we chose to do it in humans. We had very enthusiastic volunteers who wanted to contribute towards the knowledge and bringing about COVID prevention. So we had a group of individuals who took trehalose eye drops for a period of 10 days, 2 times a day. And we had impression cytology and nasal swab from the same individual before the start of this treatment and day 10 as well at the end of it. What you see there in the graph has been divided into ocular mucosa via impression cytology and nasal mucosa expression using the nasal swab. What you can observe and appreciate is a significant reduction in ACE2, TIMPRIS2, cathepsin-L in the ocular surface mucosa, and an induction in interferon alpha, and that is type 1 interferons. And there was a bit of reduction in the ocular mucosa of interferon gamma, that is type 2, and induction of type 3 interferons, that is interferon lambda 1. So what you can see in the summary is that trehalose in an individual was able to induce the beneficial alterations in the ocular surface mucosa as well as the nasal mucosa. But you might wonder what was happening in the non-treated group. In the next slide, you can appreciate that in the untreated control between day 0 and day 10, we don't see any such changes whatsoever. So what do you have in hand is a potential prophylactic, which Dr. Sharon can elaborate on how it can be used clinically.
So what we knew is, of course, that the ocular surface and the conjunctiva is a potential route for viral entry. And we also knew of the existence of the ACE2 and its how it increases the risk of infection. But what we're trying to add is the expression patterns of other various attachment or entry related genes in normal human ocular tissues, and also compared it to those tissues obtained from COVID-19 infected and recovered subjects. We also showed that unfavorable ocular surface, like for example, in dry eye patients, could also change how all these factors behave. The potential use of trehalose as a prophylactic eye drop is important, as it could reduce the expression of the attachment and also enhance the type 1 interferons, so thereby preventing the entry or transmission of these viruses. Of course, repurposing medications may help us fight in a very emergent problem. So of course, the limitations could be a smaller sample size. And of course, this is right now experimental, and we have a small pilot human study. But we hope to take this further. And these are our references. And of course, a huge round of applause and thanks to the entire team at GrowLab, led by Dr. Orko Subhraghosh and Dr. Swaminathan, and thanks to Mr. Vishnu and Dr. Trilokanath, who have worked very hard with these experiments. I now hand over to Dr. Pooja Kumar for her section of the talk.
So what Dr. Sharon had mentioned is to see what happens in the case of infection and how can we do a pharmacological prophylaxis. But now moving towards Dr. Pooja, she's going to say how COVID-19 lifestyle is probably affecting the ocular surface and how can we personalize in diagnosis and management.
Thank you, sir. So when COVID-19 came in, before we had any lead to what is going to happen, what will not happen, all of us knew one thing for sure, that we have to wear masks no matter what, and that is the most important thing which will help us prevent COVID-19. But then when we started using masks, again, there was a lot of challenges. Using of face mask increases the ocular surface inflammation, and it negatively impacts the quality of life, especially in patients with dry eye disease. And prolonged use may be relevant, and it might impact the dry eye disease. Also, on the other hand, it was of course, when you wear a mask properly, it might be okay. But if the mask is not put properly, or if there is any gaps in where you put the mask, the air might disperse around the eye in a wrong direction, and it might cause evaporation of dry eye disease. Now, we all know that, whenever there is the air which is exhaled from when we are breathing, it contains a lot of carbon dioxide. So whenever this exhaled air is going towards the eye, it actually makes your surface hyper, it enhances first the evaporation of the tear film, and it also induces hypercapnia to our surface. So we wanted to study in our lab that, whether there's an impact of mask on ocular surface. Are the mask associated ocular surface changes different from dry eye? And will it have an impact on our clinical practice? So what we did was, we had for a set of study, we had few samples of the patients for whom we had the dry eye metrics, the tear markers, and the ocular wash. So we went back and took out the same cohort of the patients where we had all the data related to dry eye, tears, and immune wash. And we called the same set of subjects who were, of course, using mask for more than 8 hours. We chose different type of mask use, and we did the same set of tests for these patients just to see what is happening on their ocular surface. So what we found interesting was that of course in the dry eye metrics, there was a increase in the Schirmer's test, like the Schirmer's test 1 value and the T-but, there was a significant increase. And at the same point of time, there was increase in the discomfort of the patient as well. There was both increase in the discomfort subscale and the vision subscale. So this was something which was not explaining what we are dealing with, because when you're dealing with an evaporative dry condition, your T-buts are reduced, your Schirmer's might be normal or reduced, and your OSDI scoring would be on the higher side. But here, if you see the T-buts are on the higher side, then what are we actually dealing with? Is this the ocular surface discomfort related to mask? And what are the factors driving the discomfort in spite of having normal tear film metrics? So again, this was what the method was used for our tear marker test and the ocular wash. We did subject them to the flow cytometry to do the molecular factor analysis and study specific cell types and quantified them and compared them the pre-COVID era and the post-COVID era. So now I would like to invite Dr. Swami to explain us what was happening in this comparison.
This question was solved because of the biorepository system and the excellent clinical colleagues, because they had documented every part of it. And what you can see here in the tear metrics, as well as the ocular wash, there is a distinct change in the immune cell subtype, very different from that of the classical dry eye. For want of time, I'm not going to get too much into that, but I want to point towards the seesaw, which you see on the left side, is there is an imbalance between a pro-nociceptive factors and an anti-nociceptive factors. And these are the ones which have been disrupted post-mask wear, because these are matched samples before and after mask wearing lifestyle. So there was a clear molecular distinction between classical dry eye and the discomfort they have experienced post-mask wear. So you can continue with that, Dr. Pooja.
So the second question was, like, a lot of them are highlighting the point that the exhaled air is going towards your eye. It's entering the eye. So of course, it's creating a hypocapnia on your ocular surface. So do you think that this hypocapnia on the ocular surface will have an impact on your eye?
We did answer that question by performing an in vitro experiment where you can see the patterns which you see in the bar graphs to the right have clearly indicated that it has recapitulated what was observed in the tear in the previous table which you have seen. On top of that, not only did the tear factors change the way we were picked up from the subjects, there was a reduction in the osmolarity. In dry eye or dryness, it's usually increased osmolarity. In our in vitro system, both in the corneal epithelial cells as well as corneal scleral rim, we saw a decrease in hypoosmolarity or decrease in osmolarity following hypercapnia. So there is a distinct difference.
So we all know that, the clinical outcomes will impact the tear molecular factors and the immune factors. So in spite of higher ocular discomfort or altered immune profiling, hypercapnia, why is the tear film stability unaltered? Why is there is an increase in their Schirmer's value and T-but value?
But that question was answered by our clinical colleagues because they knew that hypercapnia induces mucin secretion in the respiratory tract. And we went directly with that information. And what we see in the patient subject tears is that there was an increase in mucins, as well as in our hypocapnia in vitro corneoscleral explant, we saw an increase in mucins. So despite the creation of evaporative kind of a situation, there is an induction in mucin. Therefore, the TBUT and the tear film stability was maintained.
Perfect. So I think by this, we know that, of course, when we are dealing with dry eye, we are dealing with tear hyperosmolarity. But I think when we are having impact of mask on the ocular surface changes, we are actually not dealing with hyperosmolar ocular surface, but we are dealing with a hypoosmolar ocular surface. So my question to all my panelists and the colleagues is, will it have an impact on surgery, be it any ocular surface surgery, cataract, cornea, refractive, or glaucoma? Will it have treatment or impact on treatment outcomes? Topical management. The most important question apart from this is, which lubricant will work the best, and why will there be any higher chances of infection? What our preliminary results are showing is that yes, it might have an impact on delayed wound healing. topical management might be ineffective, or we might have higher non-responders. So we might have to change the drug delivery system, increase risk of infection, which is not just observed by our group, but many other groups as well, increased ocular discomfort, and probably if we don't take care of it and we go ahead and do a refractive surgery, they might land up into some complications. So I open this forum, these questions for discussion. But before that, I would like to thank our entire team back at Grow Lab and Narayan Netralaya for helping us do this wonderful work. Thank you.
Thank you. Thanks, Swami, Pooja, and Sharon. So I'd like to open up the forum. Dr. Gupta, would you like to comment?
No, it's a wonderful work. Like, I don't do ocular surface, but I was just looking at its value and how can it be extrapolated to intraocular inflammations. You know, we have been using interferons to treat some of our infections, including rubeola-induced viral infections. So I was just wondering that would it be worth a try in some of these infections? Because so far I have been able to find IL-6 and TNF, and somehow I think TNF is much more than IL-6, because many a time the steroids do not work, but anti-TNF works like a magic, which is contrary to our non-COVID uveitis, where steroids are always been the fire extinguisher. So my question to Dr. Swaminathan will be, what would be your take on giving interferons in these patients?
Okay, so here interferons, probably interferon beta is known to be an immunomodulator or an immunosuppressor. But I think Dr. Manfred has been talking about interferon alpha for quite a bit, and I'm a big fan and follower of him. So,
but
yeah.
Manfred is the only one for whom interferon alpha works, for nobody else in the world. So we don't know.
We don't know that yet, but interferon beta is something among the interferon subtypes. We have to be careful on which type of interferons to be used and on what occasions and at what concentrations, because they do have a stimulatory effect. So we have to know the milieu, know the dose, know the type, and also the route of administration.
And my last question, a quick one. Suppose we obtain the vitreous from some of these patients. What do we look for?
Which kind of disease?
Virus-induced not
right.
autoinflammation, autoimmunities. And
right.
Can it do autoinflammation? That was my second question.
Absolutely. Answer is a yes to your second question. The first question, I found a very interesting statement in your presentation. You mentioned that there is possibility of cytotoxic T lymphocytes in the retinal ganglion cell. Right, you had mentioned in one of your cases. So definitely we have to look at CDLs, that is CD8s, and NK cells primarily. And of course, we can look at autoantibodies as well in the vitreous. And there is enough publications, and our group has been consistent in finding immune cell subtypes and their activation statuses intraocular. It is possible.
And then I'll talk to you personally about autoinflammation, because I guess Chetra is writing.
Right. We'll be more than happy to discuss, ma'am.
Sure.
It's Saturday night, ma'am. So I'm sure, everybody wants a break, weekend now. So it's been a very, very good discussion. I will share Swami's and our course email IDs and numbers with you, ma'am. Would be great to discuss and also to carry work forward. You were suggesting that we should be doing some amount of collaborative work as well. Dr. TPD also suggested. So it's been amazing. We've had a lot of focused discussion. I know it's a little, probably a little too much for a beginner to comprehend all of this, but we have more sessions where we'll be covering a little more on clinical work as well. We have one chapter lined up for regenerative medicine. I think that's going to be extremely interesting as well in the coming weeks. I thank all the speakers, the panelists for having contributed immensely, taking time off to prepare these, prepare the presentation itself, because there's so much to convey in such a little time. So congratulations to all of you on your good work, and thanks for the audience for being part of this meeting. And AIOS finally, Dr. Namrata and Dr. Rajesh for being so supportive. Thanks everyone. Good night. Have a great weekend.
Yeah.